Good evening, esteemed faculty members and all the delegates. Thank you for joining. Today we are back with our series, The Benchmark, Episode 4, and the topic is the Obstetric Ultrasound Symposium. Let me introduce the coordinators of today's webinar. Dr. Monica Singh ma'am is the Consultant Reproductive Medicine, Bhopal Fertility and Endoscopy Center, Professor at Ellen Medical College, Bhopal. Ma'am has been the Managing Committee member, ISAR, Vice President of Bhopal Obsgyne Society and Bhopal Menopause Society, Honorary Secretary of MP Chapter of ISAR, and West Zone Coordinator, Medical Disorders Committee of FOXY. I welcome you, ma'am. And it's my privilege to introduce Dr. Munjal Pandya, sir. Sir is the Associate Professor, Narendra Modi Medical College, Ahmedabad, Gujarat. Sir is the Honorary Secretary of Ahmedabad Obsgyne Society for the year 21 and 22, and sir has received numerous awards. I welcome you, sir, and I hand over the session to you.
Thank you so much, ma'am. So basically, I welcome you all for today's obstetric ultrasound webinar, which will be encompassing a lot of factors, majorly summarizing the ectopic pregnancy and scan of all 3 trimesters by the stalwarts of the field. And now I would like to introduce Dr. Sneha Bhuyer, madam. Can we have the CV slide, please? Thank you. Ma'am is an international MS signature. She has received International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award in 2021. Dr. S.N. Malhotra Individual National Award for the Outstanding Work in Rural Obstetrics in 2008. Dr. Durusha Distinguished Community Service National Individual Award in 2022. Individual Award, Champion of FOXY Award for 2 consecutive years, 20 and 21, and Dhira Award for 22. Dr. Anandibai Joshi State Award by Government of Maharashtra, Lokmat Healthcare Excellent Award in 2020. She has delivered 300 plus talks, 10 plus keynotes and orations, and moderated 100 plus panels. And she has written 30 plus chapters and articles in national publications. So we welcome you, ma'am, to inaugurate or for lamplighting of this particular webinar based on obstetric ultrasound. Thank you.
Yeah, first of all, we invite all the dignitaries for the inauguration and lamplighting. So, Sahiti, can we please have the lamplighting video, please? And the prayer, yeah. Shubham kurutvam kalyanam Arogyam dhana sampada Shatru buddhi vinashaya Deepajyotir namosute Deepajyotir namosute Shubham kurutvam kalyanam Arogyam dhana sampada Shubham kurutvam kalyanam Arogyam dhana. So, thank you so much, Munjal, for that kind and generous introduction. A very good evening to one and all. Respected seniors, my dear mentors and dear fellow Foxians, a very good evening and warm welcome to all of you. Respected Chief Guest, Dr. Alpesh Gandhi, Guest of Honor, Dr. Prashant Acharya, and Dr. Rajendra Singh Pardesi. The illustrious speakers for today, Dr. Archana Basil, the past Vice President of FOXY, and of course, the past Chairperson of FOXY Imaging Science Committee. Dr. Bela Bhatt, who is the current Chair of the same committee. Dr. Kuldeep Singh, the Master Trainer of Obstetric Ultrasound. And of course, Jack of all and Master of Obstetrics, the Teacher of Teachers, respected Dr. P.K. Shah, sir. The Chairperson, Dr. Sudha Prasad, who is the past Vice President of FOXY, Professor Pooja Patil from Bhopal, Dr. Umesh Jindal, who is the Director of Jindal IVF Center, Chandigarh, Professor Dr. Gurpreet, Dr. T. Chitra from Puducherry, Dr. Neha Varun from AIMS Delhi, Madam Pramila Modi, and Dr. Amita Sinha from Patna, all the illustrious chairperson, and of course, dear fellow Foxians, a warm welcome to all of you here. This program, The Benchmark, is a focus program, and this time we are bringing to you the program basically on obstetric ultrasound. And we have selected a particular subject and invited faculties who are the authorities truly in the subjects, the experts in the field. So I'm sure this will, take you right from ruling out the ectopic pregnancy, the early pregnancy scanning, the second trimester scan, and of course, Dr. P.K. Shah sir will, make us alert about the late onset IUJ or FGR, and definitely will prevent, all the unexplained stillbirth. So this is going to be a very informative virtual program, and I'm sure it will be very useful to all of you as well. With this, I thank all the dignitaries, and I thank all the faculties for accepting the invitation and be here for this program. May I have Dr. Bela Bhatt's CV, just to introduce her. I think Munjal, you can introduce Bela and invite her.
Yes, ma'am. So Dr. Bela Bhatt, madam, she is MD OB&GY FICOG. She is chairperson of Foxy Imaging Committee for the years 2021 to 25. She is lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center at Andheri, Mumbai. She is fetal medicine consultant at Dr. Babasaheb Ambedkar Memorial Central Railway Hospital, Mumbai. She is FMF UK certified sonologist for fetal abnormalities as well as nuchal scan. She is life member of SFM, that is Society of Fetal Medicine. She is joint secretary of AFG, that is Association of Fellow Gynecs Mumbai, which is doing amazing academic work. So thank you so much for that. Managing council member of ISPAT, CS Dawn First Prize at AICOG 2018. Bhubaneswar, she is winner, that is first prize of Foxy Has Talent National Competition 2018, which I was glad to witness. National convener of Foxy
enough,
Superstar.
I think that's enough. Let's start.
Okay. So basically, we all know her, and she has been doing excellent as convener of the committee. And we welcome you, ma'am, for this particular webinar. Thank you, ma'am.
My pleasure. So I think Dr. Sneha will start with Haya. So today we are all very glad to have Dr. Alpesh Gandhi as our chief guest, and we all know sir doesn't need any introduction. Dr. Alpesh Gandhi, welcome sir. Sir has been President Foxy 2020.
Good evening.
Good evening, sir. Good evening and welcome, sir. Governing Council member of ICOG and Foxy, Chairperson Practical Obstetric Committee Foxy in 2009 to 11, Vice President Justices India Chapter, past President Ahmedabad OG Society from 2007 to 8, convener one of the most successful ICOG 2017 at Ahmedabad, which we all have witnessed. Past joint convener SOGOG, past treasurer SOGOG, and national coordinator for emergency obstetric care program of GOI and Foxy. And we all know sir has been conducting wonderful conferences of emergency obstetrics and how to manage that. Beyond and just above all this, we all know Dr. Alpesh sir as the most humble, soft-spoken, simple, easy to approach person, and in his presidential year, actually this era of webinar started, because of which we are all benefited and we are updating our knowledge and getting touch into each other, at least online. So thank you so much, Dr. Alpesh sir, and welcome to this webinar, and all yours, Mikey sir.
Thank you so much, Alpesh sir, and please we are eager to listen to your precious words.
Thank you, Dr. Bela, for the kind words and generous introduction. Thank you, Dr. Sneha, for inviting me and giving this opportunity. I'm so happy to see, as Dr. Bela has mentioned, webinar is going everywhere, in each and every corner of India. So many small societies are benefited. Practitioners working in periphery, rural area are it's very beneficial to them, and now we can invite so many international faculties easily for their expert opinion, to share their experiences. First of all, I would like to congratulate Dr. Sneha for this wonderful series, The Benchmark. This is the 4th episode. It is very difficult to continue some good work. I have seen her working very hard since 2013. I've seen her working for critical care in obstetrics. I've seen her working as a committee chairperson of the study of female breast. And during the tenure, I have also observed that not only, of course, she is working for her committee, but she was also working for so many other issues related to women's healthcare, and she was also helping other committees also. So Dr. Sneha, congratulations for your all the good work.
Yes,
And this is again, this series is also a very good series, academic obstetric ultrasound symposium. Today we are going to discuss on this topic. My high regards and namaste to today's guest of honor, my dear friend, Dr. Rajendra Singh Pardesi, Prashant Acharya, and Dr. P.K. Shah, sir. I can see him. Sir, it is good. Now we can meet you everywhere. Now you are atra tatra sarvatra. So good to see you so active. Because sometimes after being past president since so many years, it is difficult to be so active in all the academic and social events. So always happy to meet you everywhere.
Thank
A
you.
very good faculty, I would say a teacher of teacher, Dr. Kuldeep Singh. I silently attended many lectures, talks of Dr. Kuldeep Singh. It is always I got many tips from his talk. And Dr. Archana Basar, another very very great academician. And during my tenure, I got an opportunity to work with her as she was the vice president of Foxy. And during the tenure, we conducted a very good program with Fetal Medicine Foundation. It became very popular. Dr. Bela, again, I would say, she is everywhere. Again, atra tatra sarvatra. Not only in academic, whatever you go publication, if you go to talent, dance, everywhere she is there, judge, paper poster, so many. She is always present at so many level, and she is very multi-talented. There is very healthy competition between Hitesh Bhatt and Bela Bhatt. Hitesh is has reached on height of medical legal issues. And
No
Bela is
competition,
also
sir.
Bela is working so hard, and now she is also very popular. Her programs, webinars, CMEs are also getting very popular all over India. So I think one day will be there in the middle of the year. They both will meet somewhere. They both are so busy. My high regards to Madam Dr. Pramila ji, Dr. Amita Sinha, all the expert faculties, Dr. Pooja Patil Madam, Professor Chitra. So we have so many good faculties, and today we are going to discuss very important for topics: pregnancy at unknown location, first trimester anomaly scan, pulse of second trimester scan, and at the end FGR. And I think all the topics are very useful in our routine practice. Technology has brought revolution in our practice, particularly sonography. We cannot imagine to practice without sonography. It's so in each and every patient. Now it is available at each and every clinic, we can say. So it's so a useful tool, and without it, we cannot imagine to practice obstetric. So it has, I would say, brought revolution in our obstetric practice. And today we have eminent faculties, very good symposium. We are going to discuss so many important topics. I hope our delegates will be benefited a lot. And my high regards to Madam Dr. Sudha Prasad and two coordinators, Dr. Monica Singh and Munjal, my friend, dear friend Munjal and Monica Singh. Both are very punctual and very good in communication. Good evening. Very good in communication. Wherever you are, they will definitely caught you. They will remind you, and they will see that you do not forget it, and you are there. So thank you very much for a very good communication. And once again, I would congratulate and Dr. Sneha. I have worked so much with her in my so many. We have celebrated national days, international days, so many programs conducted, and she was there everywhere. And I hope my best wishes to you for all your future endeavors, what you deserve, and I hope you will be there. So once again, congratulations and my best wishes for the success of this webinar. Thank you very much for inviting me and giving this honor and this opportunity. Thank you.
Thank you so much, Alpesh sir, for all the wonderful wishes and a very good insight into the subject. Now I invite Dr. Prashant Acharya. Do we have sir here? I can't see him actually. Dr. Prashant.
I don't think he has joined.
Yeah, so we welcome Dr. Rajendra Singh Pardesi first. By the time I think he will join. So once again, a very good evening to you, Rajendra.
It's okay.
Everybody,
Sneha, it's okay.
Yes.
We can skip that. Sneha,
Yes,
we can
sir.
skip that.
Yes, sir. So I think we
good
can start
evening.
sharing. Yeah. Over
Good
to
evening, everybody. Respected Chief Guest, Dr. Alpesh Gandhi, sir. Alpesh Gandhi, sir, is a hello. Alpesh Gandhi, sir, is known as critical man, but he is not critical man. He is taking of critical care, and he is a very simple fellow. Our past president, he has done too much work. And the legendary Dr. P.K. Shah, sir, and Dr. Kuldeep Singh. We shouldn't forget their contribution in sonography field. Then respected guest of honor, Dr. Prashant, past VP, Dr. Sudha Prasad, Dr. Archana Baser, and our ever-active chairperson, Dr. Bela Bhatt. First, I wish to congratulate Dr. Sneha Buyar, our IMOC chairperson, for organizing this symposium on obstetric ultrasound. We all know USG is our third eye in the field of OB/GYN with the eminent speakers like Dr. Archana Baser, Dr. Bela Bhatt, Dr. Kuldeep Singh, Dr. P.K. Shah, sir, and all chairpersons. I think this is going to be a great event. I wish every success to this event. And at the same time, Sneha Buyar is there, Dr. Monica Singh is there. So I wish every success to Dr. Monica Singh for her future endeavor in FOXI as her chairperson in Perinatology Committee. I wish every success to Dr. Sneha Buyar for her future endeavor in FOXI as Vice President FOXI. Wishing again every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you. Thank you so much, sir. I think Dr. Prashant is joining in a while, but I think we will have his words as soon as he joins. So let me just thank all of you for accepting the invitation, guesting the program, and having your precious words. I can see Dr. Monica joining from the airport. So we will have you later in the academic session, Monica. Thank you so much, everyone. So, Sahiti, if you can just check whether Dr. Prashant Acharya has joined. Otherwise, we can start with the academic session.
Sir has not joined now.
So, over to you, Dr. Munjal, for taking this session ahead, the academic. Thank you so much.
Thank you, ma'am. Can we have the CV slide of chairpersons? Yes, Dr. Sudha madam and Dr. Pooja madam. Yes, thank you. So let me introduce the chairperson of the first session. The first session is on ectopic pregnancy. So Dr. Sudha madam is director at Matritva Advanced IVF and Maternity Center, Palam Vihar, Gurugram. She has teaching experience of more than 40 years. Past president of Indian Fertility Society 2020 to 22. Past vice president of FOXI 2019. Past president of AOGD from the year 2016 and 17. Former professor and IVF coordinator, IVF and Reproductive Biology Center, Maulana Azad Medical College, New Delhi.
Yeah. Welcome, Dr. Prashant Acharya. Munjal, can we just introduce sir and have his word?
Yes. Can we have CV slide of Prashant sir, please? Yes, thank you. Sir is Medical Director and Chief Consultant of Paras Advanced Center for Fetal Medicine, Ahmedabad, India. He is Honorary Fetal Medicine Consultant at SVP Hospital, Ahmedabad, Founder Secretary of Fetal Brain Society 2024, ICUOG Fellowship Award in 2019, first Asian to be honored with this particular award. He is ICUOG board member and trustee for the years 2015 to 19, first Indian to be appointed in such a place. ISUOG Ambassador to Asia and Pacific region for the years 2014 to 20. ISUOG International Faculty of Speakers, first Indian to be honored with the said designation. ISUOG BIDS Committee member, ISUOG Advisory Board member since 2012, founder trustee of Indian Society of Ultrasound in OB&GY, FOXY Vice President for the year 2012, FOXY Chair of Genetic and Fetal Medicine Committee 2010 to 13. ICUG Council member for the years 2012 and 16. And he has number of accolades, including being international speaker for many years, for many past years. And he has been conducting a lot of fabulous workshops, which are international workshops being attended by numerous delegates on a routine basis. Sir, we welcome you, you for the said webinar, and we want a few words from your side, sir. Thank you.
Thank you. Thank you very much, Dr. Munjal and Dr. Sneha. All the very best for organizing this 4th edition of the your webinar series. And this is a very relevant topics which you are going to discuss today, and you have all told what we are going to discuss. So rather than wasting time, I would request Dr. Munjal and Dr. Sneha to take it forward. Thank you very much, and all the very best for the not only for the present webinar but all upcoming webinars. Thank you.
Thank you so much, Dr. Prashant, for joining and having your precious words. Thank you so much.
Thank you so much, sir.
Thank
can
you.
we have the CV
Over to you.
slide of Dr. Pooja, madam? Yeah. Can we have CV slide of Dr. Pooja, madam, please? Yeah, Dr. Sudha, madam, we welcome you for the webinar to chair the first session. Next CV slide, please. Yes. Madam is present post she is holding as Professor and HOD of Department of OB&GY at LNMC, Bhopal. She has done Masters in Cosmetic Gynecology, work experiences, clinical and teaching experience of 19 years, almost 2 decades, editorial member of Turkey's journal JCOG, reviewer of BMJ case report, Curasis and IGOGR. Areas of interest, she has interest in high-risk pregnancy, adolescent health, medical education. She is member of RCOG, FOXY, ICOG, AMASI, and IFS. She has publications, like 13 publications in international journals and 11 in national reputed journals. She has 2 chapters in books in advanced concepts and in medicine and medical research. We welcome you, ma'am, for chairing the first session, ma'am. Over to you for introduction of first speaker. Thank you, ma'am.
A very good evening to all of you, all the esteemed doctors. I welcome Dr. Archana Basir, madam. She is a renowned faculty. We all know her. She is a consultant obstetrician and gynecologist and director at Akash Hospital, Indore. She has been Vice President FOXY 2020 and also our organizing secretary of AICOG 2022 Indore. She is a past fellow representative in AICC RCOG West Zone, and other past positions were Madam was chairperson FOXY Imaging Science Committee 2015 to 2017, organizing secretary ISAR 2016, managing committee member of ISAR 2018-20, and of IAGE of 2018 and 19, and ICOG 2017 and 19. She holds Guinness World Record holder, removed the largest uterine tumor. So it is my privilege to welcome you, ma'am, to speak on today's topic of ectopic pregnancy.
Hi, good evening, everyone. May I be allowed to share my screen, please?
Yes, ma'am.
Sorry about this. Yeah, good evening, everyone. At the outset, let me thank Dr. Sneha Bhoyar for involving me in this webinar which is subject of interest to me, like ultrasound. Ultrasound is, the thing which is so close to my heart. And it's good to share a screen with the stalwarts like Dr. P.K. Shah and Chairperson Dr. Bela. And it was nice to see Chief Guest Dr. Alpesh Gandhi, Dr. Prashant, and all. And thank you for very kind introduction, Dr. Pooja. Good to see Dr. Sudha and Munjal. Very nicely you are conducting. And Dr. Monica, she has made sure that I am present here. Her office has been calling to me on on a regular basis. So very good team you have, Dr. Sneha. I'm sure you are a team leader and you can lead really good team, and my all the best for your future endeavors and best of luck to you. So my topic, Dr. Sneha has asked me to speak on pregnancy of unknown location and ectopic pregnancies. So I've been looking for pictures, ultrasound pictures of PUL, and then I then realized this is the condition where you will not have any ultrasound picture, because pregnancy of unknown location is something where you don't find anything on ultrasound. So before I go on to my topic, I just want to make everybody understand that whenever you take patient for ultrasonography, especially early pregnancy scan or any scan, do the counseling of the patient. You should know your machine. You should know the history. Even if you are a ultrasonologist, you're not involved in patient's care directly, but you should at least check the history of the patient when you are taking her on the table. Do not move the probe too much or too fast, especially where you're suspecting an ectopic pregnancy. Fill form F and do not talk in the ultrasound room, because whenever you're talking or even training your trainees or talking to your colleagues there who are there for training, patient listens and then the patient takes something which you really don't mean it, but what interpretation they'll have is very different. So my content of my talk is when to perform early pregnancy scan, intrauterine early pregnancy scan, location of normal pregnancy, sweep of transvaginal sonography to see uterus and adnexa, definition of pregnancy of unknown location, how to monitor cases of PUL, ectopic pregnancy, especially scar ectopic, and differentiating point of scar ectopic and cervical ectopic and heterotropic pregnancy. Early first trimester scan that is performed before nuchal scan is usually performed before 10 weeks. Although the gestational sac can be seen on transvaginal ultrasonography as early as 4.5 weeks, the best time to do a viability scan is after 6 weeks, as it allows all parameters to be assessed. Various studies have demonstrated its advantages: earlier transvaginal sonography, earlier detection of pregnancy, increased detection rate of ectopic pregnancy, and better detection of signs of impending failure of pregnancy. Detection rate of subchorionic bleeds, blebs, and retroplacental hematoma is higher compared to transabdominal scan, and no need for uncomfortably full bladder. It is time saving and there is better visualization. It's important if you are performing an first trimester scan, especially the early pregnancy scan, because most of the gynecologists are performing the early pregnancy scan and up to early pregnancy scan like viability, and then probably they switch it over to the ultrasonologist colleagues. So it's very important for them to know what appears when. I mean, you can have this graph in your under the table also, or in your sonography room, that at 4.5 to 5 weeks there will be gestational sac, yolk sac at 5.5 weeks, at 6 weeks embryo appears, and at 6.5 to 7 amniotic membrane, 7 to 8 weeks spine appears, and head curvature separates from body, 4 limb buds appear 8 weeks, 8 to 10 weeks, rhombencephalon develops. Now, location of normal pregnancy, the position of normal GSA is mid to upper uterus. As the sac implants, it should be adjacent to the linear central cavity echo complex without displacing or deforming this landmark. So these are pictures of location of a gestational sac. This is a gestational sac which is normally placed, and this is a low implantation of the pregnancy. So this is how in the transvaginal scan you will be holding.
Showing the corresponding image that you will see on the probe position. So if you keep the probe like this, then you will see a sagittal section as shown here.
So this is the sagittal section. You should scan in both sagittal section as well as in the transverse section so that you don't miss the number one location and you don't miss the multiple pregnancies. Sometimes if you are only taking the one sweep in the one direction, you might miss the another sac. So this is how you will be doing your sagittal section. Then this is a transverse. You have to hold the probe like this to do the transverse and see how in the transverse the position of the gestational sac and the view of the uterus you see is different when you are doing a transverse section of the uterus. You are like seeing the other from the other angle. So now let's come to the pregnancy of unknown location. What is the PUL? Pregnancy of unknown location. It's number one. It's very difficult to explain to the patient that you are pregnant, but I don't know where is your pregnancy. That is really, really very difficult. So pregnancy of unknown location means you have a positive pregnancy test, but you cannot identify on the ultrasound pregnancy. Now this can be because of three possible reasons. Number one, either it's a very early pregnancy within the uterus that is too small to be seen on scan, or may have miscarried, patient might have miscarried, and your pregnancy test can remain positive up to 2 to 3 weeks following a miscarriage, or may have an ectopic pregnancy, because PUL are associated with ectopic pregnancy, but this is not synonymous to the to the ectopic pregnancy. The concept of combining ultrasound with serum HCG using a discriminatory zone is being widely evaluated. It refers to a defined level of HCG above which the gestational sac of an intrauterine pregnancy should be visible on ultrasound with sensitivity approaching to 100%. And the current recommendation value ranges from 1000 to 2400 international unit on transvaginal ultrasound. Now, according to Association of Early Pregnancy Unit guidelines, if no intrauterine or ectopic pregnancy or written product of conception are seen on TVS and the woman is asymptomatic at initial assessment, she can be managed conservatively, because most of PUL may not require any treatment and the pregnancy may be just this, absorbed, or it goes. This involves re-estimation of serum beta HCG levels at 48 hours to determine the pattern of HCG changes from the initial assessment. The pattern of rising or falling HCG afterwards and the HCG ratio are useful in distinguishing between pregnancy of unknown location that will develop into a intrauterine pregnancy or a PUL from intrauterine and ectopic pregnancy. This is particularly the case whenever the HCG levels are lower than the discriminatory zone, or when an ultrasound diagnosis cannot be made despite the HCG being above the discriminatory zone. So rise or fall in HCG, I mean, we all know, we have been asking the patient to do one HCG and then repeat it after 48 hours. So however, like there are 13 to 21% of ectopic pregnancy have been an HCG rise that mimics an intrauterine pregnancy. So you can not entirely rely on the, doubling of the HCG within the 48 hours. So if HCG levels fall by at least 15%, the most likely outcome in failing pregnancy of unknown location, although 8% of ectopic pregnancy have a fall in HCG similar to spontaneous miscarriage. So whenever you are following a woman with PUL and you see that the HCG levels are falling from the previous report, you can have a sigh of relief that yes, it is going to be a failing PUL, but still you have to keep the patient under observation because some might still be ectopic. So this was a review of pregnancy of unknown location and evidence-based approach to management by Haritha Segil and Kemel Mahmood. This is an algorithm like how really to monitor a PUL if the women are asymptomatic, and when they are symptomatic, asymptomatic, do the expectant management, falling level, you can just call them once again to see the HCG level. And if the, levels are suboptimum and still look for the ectopic pregnancy, don't let them off the hook. Monitor them because they may still have ectopic pregnancy. Now let's move on to the ectopic pregnancy. We all
What happened?
or the most common form of ectopic pregnancy. So this is a tubal ectopic scene separate from the ovary. What you can see in the ectopic pregnancy is that uterus is empty, and you see in the adnexa, and if it is a tubal ectopic, ovaries also you will be able to identify. So this is a TO mass where you can see a patient has positive pregnancy test, absent intrauterine gestational sac, and there is a TO mass, and ovaries are separate. This is another picture of ectopic where you can see some blood in the pouch in the peritoneal cavity, and this is the gestational sac in the adnexa, and ovary is seen separately. This is a ectopic pregnancy with gestational sac and a yolk sac in the adnexa. So I mean, if you know and you are very good that not only I'm going to see the uterus, I'm going to see the adnexa whenever I'm scanning, you are highly likely to pick up the ectopic pregnancy. This is a ectopic pregnancy where there's a ruptured ectopic with a big hemoperitoneum, and we took the patient immediately for the laparoscopic procedure because she was little unstable vitals. And then this is a picture with a corneal ectopic. Again, the uterus is empty. There's a high vascularity at the cornea. And then scar ectopic, which is on increase these days because there's an increased number of the cesarean section. Hence, the scar ectopic is also increasing. So incidence of a scar ectopic is like 1 in 1800 to 1 in 2000. So incidence of scar ectopic in women with previous C-section is 0.15%, and 6.8% of all ectopic pregnancy these days are scar ectopic. And because of small number, it has not been determined if the number of type of cesarean section delivery affect the risk of cesarean scar ectopic. Now CSP, like that cesarean scar pregnancy ectopic, they can be classified into two types. Type 1 endogenic CSP and type 2 is exogenic CSP. Endogenic CSP where implantation occurs inside in the scar in the gestational sac, grows towards the cervical isthmus and into the uterine cavity, and exogenic CSP means when the gestational sac grows towards the scar and it grows towards the bladder. And diagnosis can be particularly challenging and needs a high degree of suspicion. And it has to be differentially diagnosed from threatened abortion, missed abortion, inevitable, tubal and cervical ectopic. So criteria for diagnosis of scar ectopic on USG, number 1, ask the patient to empty the empty the bladder, that is for the TVS, empty uterine cavity and closed and empty uterine cavity, placenta and or gestational sac is embedded in the previous cesarean scar, a triangular round or oval shaped gestational sac in the niche of the scar, a thin or absent myometrial layer between the gestational sac and the bladder, yolk sac, embryo and cardiac activity may or may not be present, and evidence of functional trophoblastic placental circulation on color flow Doppler examination. They are characterized by high velocity and low impedance blood flow, negative sliding organ sign. This is a picture of, this is a tubal ectopic pregnancy. If you see here, this is adnexa, and this is a gestational sac, yolk sac, and a little fetal pole is also seen. This was 6 weeks, 5 days, and this is a uterus with a empty uterine cavity. This is a scar ectopic. See again here, this is the contour of the uterus. This is the endometrial lining, and this is the scar anteriorly, and what you see is the gestational sac. Here, this is a scar ectopic here. This is again a patient with a previous 2 cesarean section, and look here, there's a live embryo of about 7 to 8 weeks with a scar ectopic. Upper segment of the uterus is empty, and you see here that this is the cervical canal, which is here, and this is in the myometrium here. And then this is just a small hysteroscopic picture of CSP in which is inside the uterine cavity. This is a gestational sac, which we could do it with the hysteroscopic management only. And then like just to summarize the take-home point from ectopic and PUL, always think ectopic. Whenever a woman comes to you with pain in abdomen, bleeding, and a positive pregnancy test, you cannot see anything in the uterine cavity, think of ectopic. Keep a watch on serial level of beta HCG in cases where intrauterine pregnancy is not seen. Counsel the patient and relatives when pregnancy of unknown location regarding risk of ectopic and necessity for the follow-ups, because today you are not seeing pregnancy, today you are not seeing ectopic, but tomorrow she may come with an ectopic. So look for adnexa in every early pregnancy scan. You may get surprises in form of heterotropic pregnancy. You may have intrauterine pregnancy, but there may be a gestational sac inside in the adnexa as well. So there are cases of reported of heterotropic pregnancy as well. So thank you very much for the patients listening, and I really enjoyed making this talk.
Very well, Dr. Archana explained the PUL, because it is a very, very interesting topic where everything becomes so stressful. Clinician also and the patient also, both are stressful that what's going on about this of unknown origin ectopic. So it is really requires a very close monitoring, number one, and number two, that we should follow up with the beta HCG and progesterone also. If the progesterone is high, more than 20 nanogram, probably yes, we are dealing with the right pregnancy only. And if it goes beyond 3,500 beta HCG, then what to do? And we cannot see by ultrasound many times, because I remember a patient had a secondary abdominal pregnancy. Can you imagine? And all the time we were trying to feel, and it was a uterus is nowhere. We kind of ballooned up abdomen, gut was so ballooned up, we couldn't see anything till the baby became 28 weeks, when we said, no, now I think she is she conceived in the lactational amenorrhea, feeding the child also, nothing was visible, but she was little, dicey, not very, vitals were little on the lower side. So finally, when we found that it is from the abdominal aorta, the placenta is attached and the whole uterus is smaller in size, and the baby was in the peritoneal cavity. So immediately emergency section was done, and it was very, very difficult. We left the placenta. So any problem can occur to this kind of problems, if the pregnancy we cannot see by ultrasound, then it becomes a real difficult task. So nicely, you have explained very beautifully for the listeners. Thank you so much.
Thank you, Dr. Sudha, for your nice comments. And I'm sure that there will be some take-home points that when there is a beta HCG positive, do keep under follow-up. I don't know, all of you must have faced very difficult to explain to the patient when beta HCG is there and the pregnancy cannot be located. They keep going from one place to another, one doctor to another, that probably we are not, expert to see it. Somebody else might see it. So it's very difficult.
Do you give methotrexate if
yes,
the beta HCG is high?
Yes, when beta HCG high and you are following up and you cannot see, when it crosses that level, then I mean you have no choice but just give the methotrexate.
But all the time there is a fear that there will be a breach of vessel and the patient can land up in a acute abdomen with the peritoneal cavity blood.
Yeah,
so
I mean,
this is another.
Yes, so you go by the criteria of ectopic pregnancy. I think we have to follow those stringent criteria for
yes, very rightly said.
Thank you so much, Madam Sudha Prasad and Dr. Pooja Patil, for gracing the program and chairing the session. Wonderful inputs from you, and Dr. Archana. Thank you so much. I can see Dr. Prashant making a comment. What is the role of progesterone in such pregnancies, pregnancy of unknown location?
If the progesterone level is high, that means pregnancy is intact, and you have to keep the close monitoring, because if you leave, you cannot think of that it is aborted. The pregnancy is aborted, and probably because progesterone level is high, then you have to really monitor, because this patient can land up in problem within few days. So very close monitoring. Either you admit this patient, it cannot be a domiciliary approach. She should be in a hospital with a very close monitoring. That is most important. Of course, we do the beta HCG, but Another parameter is progesterone level, serum progesterone levels.
I think there are very means not many, but yeah, few prospective studies of progesterone level in pregnancy of unknown location.
Yeah.
Less than 2 is a low risk, and more than that is a high risk pregnancy. I think
is the high risk patient. So very closely
Thank you
to
so
be
much. Thank you so much, and over
So
to you.
all the best, Dr. Sneha, for your future endeavor.
Madam, thank you so much. Thank you so much. I need your wholehearted support as well.
All the best, Neha and Monica. All the
Thank you, ma'am.
Thank
Thank
you.
you, ma'am.
Monica, nice to see
Thank you. Thank you, ma'am. And thank you for accepting the invitation, ma'am. Thank you for accepting the invitation on one phone call. I'm so indebted on behalf of Sneha, ma'am.
You have called me, then I have to. I cannot say no.
So, so, madam, can we proceed to second session?
Please, second talk.
Greetings from T3 Delhi. And I'm your host for the rest of the evening. I'm your coordinator for the rest of the evening. And for the second session, we are not at rest because the pregnancy of unknown location has already been tackled with. But Dr. Bela Bhatt is here to say that even the first trimester screening is another big hurdle in front of us, which has to be crossed before that expectant mother can be told that she is safe. To chair this interesting session on first trimester anomaly scan, we have none other than Dr. Umesh Jindal, madam, and Dr. Gurpreet Kaur. Dr. Umesh Jindal is director of Jindal IVF and Sant Memorial Nursing Home, Chandigarh. She is a former assistant professor of PGI Chandigarh, a very premium institute of the country, former fellow University of Washington, Seattle, and Kansas City, USA. She's a pioneer of ART in Chandigarh with over 2 decades of experience in IVF, first to start IVF ICSI vitrification and PGT in Chandigarh and the northern part of India. Madam has been the vice president of IFS 16 to 18 and Northern India OBGY Society. She is also instrumental in starting the IFS Amity ART Diploma course in 2014 for the first time. She is section editor, Clinical ART Journal, Fertility Science and Research. She has organized several great conferences, which I have also taken part, and have just marveled at her, ability to organize, to teach, and to basically form a very nice network of fellows with her. Madam is a member of great international organizations, founder secretary for Greater Chandigarh Chapter IFS, which she has one of the best integrated IVF team awards in her center. Madhurima, Editor's Choice Bhaskar Woman of the Year awardee with many national and international publications. Welcome, Dr. Umesh Jindal, ma'am. Next, I would like to welcome our chairperson for the evening, Dr. Gurpreet Kaur Nandve from Bhopal. She is the professor and HOD of Department of OBGY at People's College of Medical Sciences with a total teaching experience UG/PG of more than 20 years. She is an active life member of IFS, FOXY, and she has expertise in the NDVH, difficult vaginal surgeries, reconstructive vaginal surgeries, and managing high-risk pregnancies. She has several publications in national and international journals, is an awardee we can see in AMPOX, which is the all MP societies, and is very active in the Bhopal Obstetric Society as well. Welcome, Dr. Gurpreet. Now, please introduce our speaker for us. Thank you.
Can we skip this? I have been introduced before, so can we just skip this? We can directly start with the talk. Can I share my screen?
Yes, Bella. Please go ahead.
Just adjust my screen so that. Okay, is it visible?
Yes, ma'am.
Fine. So at the outset, I would like to first of all thank Dr. Sneha Buyar for inviting me for this wonderful webinar and making me part of it as a convener. And we all know Dr. Sneha Buyar as a very, very brilliant academician and doing lots of academic activities, not now, but since years together. So before I even started working in Foxy, I've seen Dr. Sneha Bhuyar working very, very actively, doing very good academic work. So congratulations,
Thank you, my dear. Thank
Dr.
you.
Bhuyar, and all the best for your vice presidential candidature in Foxy. Are all best wishes for the same.
Thank
I'm
you.
also honored today to share this stage with many of these stalwarts, Dr. Archana Base, Dr. P.K. Shah sir, Dr. Kuldeep Singh. Thank you so much for making me part of this. Now we'll start with our academics. So I'm going to speak about first trimester anomaly scan. So we all know that traditionally since years we have been doing the second trimester anomaly scan, which is done from 18 to 22 weeks. And we have been picking up quite a few anomalies through that. But now we all know that the spectrum has also shifted to early anomaly scan, that is done with nuchal scan. Nuchal scan initially started with finding the risk for various common chromosomal anomalies, trisomy 21, 18, 13, and some common chromosomal problems. But we know that now there are many, many more things that we can obtain from the same nuchal scan or the first trimester scan, whatever you call it, right? So we know that the incidence of Down syndrome is 1 in 800 in general population, whereas that of the fetal structure anomaly is 3 to 5 per 100. It's more common. And with years when we were scanning for the risk assessment for trisomies, we realized that 50 to 60% anomalies we can pick up right at 3 months. So why wait till second trimester anomaly scan? Right. And that's how Nicolets has proposed this inversion of pyramid of antenatal care. Try and abstract as much information from these nuchal scan as you can. Risk calculation for early preeclampsia is not today's topic, so I'm not going to speak about it, but mainly because of better skill, better machines and better resolution, higher end machine, that we are able to pick up so many anomalies at third month. These and many more anomalies have been picked up at my own center, but we must remember there are 9 anomalies that should 100% be picked up at nuchal scan. These are acrania, alobar hydrocephaly, encephalocele, iniencephaly, body stalk anomaly, limb reduction anomaly, exomphalos, gastrocystis, and megacystis. And friends, I assure you will see each of these through the talk. So the basic concept is, when you want to pick up anything abnormal, you must know as to what is normal. You must know the normal findings. Then you'll be able to pick up as to what is abnormal. So typically when we do a nuchal scan, we first confirm the viability, that is the cardiac activity, and patient is also would always like to see that the fetus, the heart cardiac activity of the fetus. So that's the first thing we confirm. Then, as I said, the nuchal scan initially started for, risk assessment for aneuploids. The first step in that is to look at a standard CRL, or the crown rump length. Now, while doing so, only we realize that when we look at this standard mid-sagittal section of the fetus, which has to be taken in this manner, not going to details of it for paucity of time, but in this itself, this section itself, we can get so much information in the both sagittal and axial sweep. So you can see in sagittal sweep, we start from the one side, we can see all 4 limbs, we can see the mid-sagittal section of the fetus and get a lot of information, and as well as in the axial sweep that we take from the head to bottom. We can see so many structures as you start from the head to bottom, and we'll talk about them all. Now, what can you see in this mid-sagittal section that you take for CRL? Well, you see the intact cranium, we see the intact abdominal wall, we see the stomach here, we see the diaphragm, we see the bladder here, and we always look at the ductus venosus also in the same section. So this mid-set section itself gives a lot of information. And when there is any abnormality in this, as you can see here, the cranium is not intact and there is acrania, and not only that, the brain is overhanging, there is exencephaly. So you can make out that this is the anomaly that you can pick up. Just a minute, I just shift this. Okay. This is acrania with holoprosencephaly. There's monoventricle with fused thalami. Some of the slides I'm just going to skip because there are many, many anomalies that I want to show here today. Body stock anomalies, gross anomaly. You cannot miss it at 3 months because the fetus is almost connected with the placenta and a very, very short or no cord is there. Obvious gross lethal anomaly, and patient would want to terminate this. This is a case, interesting case where 12 weeks, 5 days, a non-consanguineous marriage, 33 years, third gravida, previous one missed abortion, one female, 8 years, and mother was Rh positive. And on ultrasound at 3 months, there was subcutaneous edema along with fluid in the peritoneal, the pleural cavity. This was hydros fetalis, and the patient wanted to terminate its pregnancy. But remember one thing, a single principle, whenever you find any anomaly in the fetus at 3 months, we must try and find out and investigate the cause of the same. And whenever there is any kind of anomaly or hydrops at 3 months, there are very, very high chances of some chromosomal or genetic cause. So there are always 3 options. Either we can go for CVS, that is antenatal testing, or if at all patient is not ready for antenatal testing, then you must do fetal testing. And when you terminate for lethal anomalies or patient not wanting to continue, always do a fetal tissue testing that you can send to the genetic lab. And if the patient is not ready for that also, third option is DNA storage, which is a very cheap option wherein you have to send the fetal tissue to the genetic lab and they preserve the DNA of the fetus, which the patient, we can investigate maybe after 3 months, 6 months and try and find out the cause. Why is this important? Because if the patient wants future pregnancy, then this is very, very important to rule out genetic cause, because some of the genetic causes are recurrent. And if they are autosomal recessive or dominant, there may be 25 to 50% chance of recurrence. So the genetic testing starts with that. It doesn't end by terminating the pregnancy. So in this particular patient also, the fetal tissue testing was done, microarray was done, and it did show trisomy 21. So it's extremely important for us to find out the cause and then prognosticate and try and counsel the patient for the next pregnancy. This is obvious. This is a case of exomphalos, as you can see in both image as well as video. The other case, again, with exomphalos. Now remember, omphalocele or exomphalos is a condition which is treatable. First thing, as I said, we have to try and find out and rule out any genetic cause. Now, this particular, the exomphalos is very, very big. You can see it is bigger than the abdominal circumference also. Right? But this patient wanted to take a chance. So genetic testing was done, and genetic test in the microarray did not show any abnormality, no relevant copy number variation seen. But there are some prognosticating factors here. Usually these ratios are taken late in the second, third trimester, but even at 14 weeks, the ratios was showing that the mass was too big and therefore there was poor prognosis, and which showed that primary closure after surgery, even if there was no chromosomal cause, was very, very unlikely. 2 to 3 surgeries may be required, and that too result was not guaranteed. We always take pediatric surgeon's opinion in such cases. Patient is sent with the report and they counsel well as to what will be the postnatal outcome. This is also extremely important even when the patient wants to continue the pregnancy. So in this case, the prognosis was poor, and therefore they then they wanted the termination of pregnancy. But that's the importance of working out the case and doing needful antenatally as well. Now, at 12 to 13 weeks, when we look at this sagittal midset section, we should be able to see bladder in almost all cases, right? Kidneys and the renal arteries is also something you can find out, but then all renal anomalies cannot be ruled out at 3 months. We have to wait for a 17, 18, 19 weeks scan for the same. This was a case where the bladder was absent at normal place and there was a mass and which was flanked. This was very old case of 2017. The bladder mass was flanked by 2 umbilical arteries, and it was case of bladder extrophy, a very, very, very rare anomaly. Now, One more anomaly of bladder is megacystis, and this is something which should be 100% picked up at your nuchal scan or first trimester scan. Whenever the longitudinal bladder diameter is more than 7 millimeters, between 7 to 15 millimeters, there are 20% chance that there can be some associated chromosomal abnormalities. But like in this case, if the bladder diameter is more than 15 millimeters, there are very, very high chances that there will be some structural cause or some obstruction of the lower urinary tract, which can lead to this megacystis. And when you can see such a huge bladder, we can see that this is nothing but bladder because it is flanked by 2 umbilical arteries, as you can see in the video clip. So this megacystis early on at 3 months has very, very poor prognosis. Not only that, it had back pressure changes and there was bilateral hydronephrosis with dysplastic changes in the kidneys. So this obviously had a poor prognosis, but I had a case when this the megacystis occurs or when these changes occurs late in the pregnancy, late second and third trimester, then we can pull on the pregnancy till 34, 35, 36 weeks. And then this baby I had delivered at 34 weeks because of severe oligohydramnios and sudden increase in the size and changes in the the overall case, the Leica reduced suddenly, and maturity was achieved 34 plus. So then the section was done in front of in presence of pediatric urosurgeon, who immediately took care of the lesion, and then after a few days the surgery was done, and that baby is surviving. That is case when it is detected late in the pregnancy. When you have such huge megacystis early in the pregnancy at 3 months, the prognosis is generally poor. Now, this was again a very interesting case where she was third gravida, previous 2 babies not alive. No papers were available, but they said the patient described that the sonography, they said they maybe had some fixed flexion deformities in the last pregnancy as well. This time when I did a nuchal scan, there was fixed flexion deformity in the fetus, as you can see, both upper and lower limbs continuously for half an hour, the same position. Baby didn't change the postures of either the upper limbs or lower limbs. So it was a case of arthrogryposis. And again, because this was the third time, last time also they said similar findings were there on the ultrasound. So they were from a government hospital and they wanted to go back to the government hospital. But it was clearly mentioned in the report that this time, if even if they don't do antenatal testing, at least fetal tissue should be sent for genetic testing, and both the parents should also be tested. And that's the same thing which was done in the government hospital. They did send the fetus as well as parental tissue for genetic testing. And what was found was the fetus was affected by cozy-related disease, which is a autosomal recessive disease, and both the parents also had heterozygous carriers, and therefore this report was in hand at the end of the pregnancy. So when they came this time in current pregnancy, they came to me right from early pregnancy. At 12 weeks, I did a nuchal scan, which was low risk, followed by which I performed the chorion villus sampling, and that sample was sent for the same cozy-related mutation. And fortunately, this baby was not showing that mutation, and therefore they continued the pregnancy. And just 12 days back, this baby has delivered by C-section, female of 2.5 kg, who is not affected. So that's the importance of working up before the patient conceives. Whenever there is a history of some genetic disorder, it's important to have the mutation in hand before the patient conceives, so that at 3 months, we can test for the same mutation in this whenever there is autosomal recessive or dominant case, and then we can prognosticate whether this particular baby is affected or not, and then we can counsel the patient and help the patient. In the sagittal, in the head, we look at the sagittal, axial, and coronal section for nuchal translucency, intracranial translucency, and in that also we can have some surrogate markers for spinal deformity. So whenever we find this is a case where you can see the brainstem is thickened and the intracranial translucency is reduced, the BS to BSOB ratio is increased, and you can see here in the video clip that there is kyphosis, and there is here in the axial section, you can see the spine opening up. There was spina bifida here. So it's a spinal defect which is giving rise to cranial signs, which are the secondary signs. So whenever you see this signs, secondary surrogate markers in the brain, you have to look at the spine very, very carefully and try and rule out the spinal deformities. In this particular case, there was also a crash sign, that is because of the pulling of the cerebellum, which is developing. You can see the crash sign because the IT, intracranial translucency, is going to reduce, the cisterna magna is going to reduce or is going to get obliterated, giving rise to crash sign. So these are all surrogate markers. You can pick up some of the spinal anomalies. In the axial scans, not only that, you can see even the orbits, the premaxillary triangle, you can rule out the cleft palate, the retrognathia, everything. When you look at these images and clips closely, the same in the image formation. Axial section, beautiful choroid plexus has to be seen, which will be absent in the holoprosencephaly, acrania. You can find out the vault is defective. Encephalocele can be picked up. So this was a very, very rare case where there was arrhynia. The nose was completely absent, as you can see here. And this particular case also had a holoprosencephaly, and obviously for this gross anomaly, patient wanted to terminate, but as I said, we always test, and this fetal tissue was sent for genetic testing, and it turned out to be trisomy 13. Okay. This was a case of encephalocele. You can see the defect posteriorly. This was interesting case where I suspected the rhombencephalon was little larger than normal, and followed up at 9 weeks, confirmed at 11 weeks that this is a defect. This is a developing encephalocele, as you can see here. And at 12 weeks, the patient wanted termination because it was a major CNS anomaly. And again, we sent this tissue. You see, externally, it looks a small defect, but internally, it's a major CNS anomaly. So the tissue was sent for genetic testing, but it turned out to be no genetic cause here. So we have to, again, when there is such anomaly, I'm talking about this isolated anomaly. When there is associated other anomalies, obviously genetic cause is more likely. We also look at the stomach, bowel, bladder, the diaphragm, and try and pick up some of the anomalies related to that. This was a very interesting case where the stomach at nuchal scan, the stomach was in the chest, pushing the heart to the right side. This was a case of diaphragmatic hernia. You can see stomach is absent in the abdominal section, and it is going in the chest and pushing the heart to the right. Again, in the sagittal section, you can see the stomach in the chest, and it is seen behind the heart in the sagittal section, in the thorax, and it's absent in the abdomen. So very early herniation of stomach and bowel in the chest, again a poor prognostic marker. I'm not going to details of prognosticating of the question of the same. Cardiac evaluation, we can start with the situs, and we can always, 3 things we can look at the nuchal scan, that is the inflows, the outflow, and the cross sign. That will rule out some of the major cardiac anomalies. Of course, not all, but major cardiac anomalies can be ruled out right at nuchal scan as well. And we always look at the ductus venosus also, and ductus venosus waveform. And we know there are some of the markers of cardiac anomalies, that is the increased nuchal translucency, A-wave reversal in ductus venosus, and tricuspid, when you find the regurgitation in the tricuspid valve. These are all markers which tell you that they're 3-fold higher. This is a A-wave reversal in the ductus venosus, which tells you there are 3 times higher chances of cardiac anomaly. Look at the heart closely. This was a case where the ductus venosus was abnormally inserting in the inferior vena cava. As you can see here, it is directly inserting in the inferior vena cava. So either absent ductus venosus or abnormal insertion, in which again there was a reversal of A wave. So here there was also high NT. So these are basically, what I'm trying to tell you is, you may not be able to reach to the diagnosis of cardiac anomaly, but always look at the marker. Whenever there is high nuchal translucency, reversal of A wave in ductus venosus, these are markers. Look at the heart closely, and you can at least rule out some of the major anomalies. If not, you can call the patient after a week, 15 days, re-look at the heart, and you may be able to pick up some of the anomalies. This is a primary gravid patient in whom, again, you can see a huge cystic hygroma here. And Also fluid in the cavities. So it was a high drops and with a cardiac anomaly. This was a case of AVSD. And again, the fetal tissue was sent for genetic testing, and it did. Again, there are markers, as you can see, cystic hygroma and reversal of inductus venosus, and with cardiac anomaly, AVSD, and the genetic testing did show Turner syndrome, which is very common with such huge cystic hygroma. So this will tell you, that this is a Turner syndrome, and if there is some genetic cause, then a recurrence and all can be discussed with the patient. Stomach should always be seen at an anomaly scan, and when it is absent, you may have to look for it closely for some time, and you may be able to rule out some of the GI anomalies. But again, you have to re-look at these babies maybe after a week, 10 days. Any gastroschisis or omphalocele can be ruled out by axial or sagittal section. This is omphalocele. We have already discussed about this. The upper and lower limbs can be seen very well at nuchal scan, as you can see in the clips as well as images, better than your second trimester anomaly scan, because usually you can see all 3 segments of upper limb like this, or the lower limbs as well like this, and therefore some of the major anomalies of the limbs can be picked up. We know there was a case where the sonologist was sued for absent hand. 1.4 crore compensation was given. So it's always better to closely look at these 3 segments of upper and lower limbs at nuchal scan. Now, this particular patient had polydactyly at nuchal scan and didn't find any other anomaly at that particular time, but I called her for early anomaly scan, and patient came at 17 weeks. And see, what you see there is bilateral dysplastic cystic kidneys, and there was almost absent liquor, absent bladder. This was a lethal anomaly because the kidneys were non-functioning and patient wanted to terminate. Of course, the tissues were then sent for DNA storage. Spinal anomalies, we have to look at it in the sagittal section, coronal section, and you can pick up some of the gross spinal anomalies like this. Well, I'm going a little quickly. So the benefits of early anomaly detection is when parents want to terminate the pregnancy, even when it is lethal or not compatible with life. When we pick up at 3 months as compared to the second trimester, it allows for earlier and safer termination, lesser risk to mother, favorable cost-benefit ratio, and the couple can protect their privacy. Not only that, even if the patient wants to continue, they have done the genetic test, as for example, with examphilus, small omphalocele, and there is no genetic cause, they want to continue, it gives them time to prepare for postnatal treatment, and consultation can be done, where to deliver the pregnancy, place can be decided, so we can get a better pregnancy outcome in such cases. And in those high-risk patients where this patient is diabetic or is on anti-epileptic treatment, where we know that there are higher chances of fetal anomalies, well, reassuring them at 3 months that at least 50 to 60% major anomalies have been ruled out is very, very good for these patients. We are also here to see the smiles on such patients when we can rule out some anomalies. And when in obese and patients with previous 2-3 scars, we know that even second trimester anomaly scan is very, very difficult. So those who are doing, they know very well. So here the nuchal scan, if you do a transvaginal scan, you can see the structures beautifully, and you can rule out many, many major 50% anomalies. Now remember, there are limitations of anomaly scan at 3 months. There are some anomalies which can never be picked up because these structures have not developed yet. Microcephaly, cerebellar anomalies, agenesis of corpus callosum, achondroplasia, pulmonary sequestration, CCM, some of the bowel obstructions. These are the anomalies which will be picked up in late second and third trimesters. They cannot be picked up at nuchal scan, and therefore, there is a medical legal importance that whenever we do anomaly scan, early anomaly at 3 months, we must tell the patient that only 50% anomalies can be picked up, and it does not replace the second trimester anomaly scan, which has to be done between 18 to 20 weeks, because that's the time we'll be able to pick up 90% of anomalies. There are still 10% which are evolving in the second and third trimester, but 90% we'll be able to pick by second trimester. So this is what has to be explained at the end. So, but these are some of the anomalies. As I said, the always detectable 9 anomalies are the ones which should never be missed. and acrania or such anomalies which I have described should never reach second trimester. We must help our patient pick up these anomalies, and well, even in the remotest area, these gross anomalies, by little training, you will be able to pick up. And I think in the rural areas also, we should try and pick up these anomalies so that we can help our patient. And with this aim only, I have been always telling that as a chairperson for the Imaging Science Committee, I want to see every obstetrician and gynecologist becoming a sono obstetrician and gynecologist. We must learn to do scan of our patients. Then we'll be able to help our patient, because every patient that walks in our chamber needs ultrasound. And for that only, I have been working since last 2.5 years and shall keep working towards the same aim. Thank you so much for patient hearing. Thank you.
Thank you so much, Dr. Bella. I would request the chairpersons to comment on the talk. I can see Dr. Gurpreet. Yeah.
Yes. Good evening, ma'am. Good evening, Bella ma'am. It was such a nice talk and very informative, and especially the pre-genetic counseling which you have posed on. This is like a good idea. We can go for an early trimester scan, since we are not getting it done regularly. The kind of scenario we are working in, I'm working with the semi-government hospital, private hospital, but for sure to our PGs, we have so many PG students. I would convey this, all these things. This is such a information, very good information. And with all the anomalies, what we can pick up in first trimester, we could counsel the patient for the pre-genetic counseling, and it could be safe for the next pregnancy. Thank you, ma'am. Such an informative talk. It is.
Just one comment, Dr. Gurpreet. You said semi-government setup. As I said, you must be getting a nuchal scan done.
Yes, ma'am.
When it is done by a trained sonologist, when he looks at the CRL, when he looks at the NT, the 9 always detectable anomalies will always be picked up. They cannot be missed. They are so obvious, they cannot be. So at least that much minimum is something which can be done even in the government hospital where nuchal scans are done. If you are not getting nuchal scan done is a different issue, but if it is, because as I said, this is more important than a Down syndrome.
Yes, ma'am.
Yes, common also. So these gross anomalies at least can be picked up.
Sure, ma'am. And such a information, very good information, ma'am. Thank you so much. Even it is like very informative for me. I'll convey to my colleagues also. And as we have so many PG students in the radio department also, ma'am, and in my department also. And from your lecture, ma'am, I'm planning that I'll take a lecture on this for the sonologist and my department. Thank you, ma'am. Thank you so much.
Thank you, Dr. Gurpreet. Thank you, Dr. Gurpreet.
Monica, there are some queries, one or two. I think
yes, ma'am.
You can raise it
yes,
for
ma'am. Madam Bella ma'am, there is a question from Dr. Aparna Gupta that she has a patient of 13 weeks mean gestational age. Her fetus has pleural effusion and moderate pericardial effusion on ultrasound. What is the treatment for this? Is it an indication to terminate the pregnancy? Please guide.
No. So first and foremost thing is termination is not the answer. We have to try and find out the cause. So whenever this is a case of hydrops, when you have more than one cavity which has fluid, it is a case of hydrops. Now, early hydrops, we must know the causes. There's an entire talk on this, but quickly I'll just tell you that there are various causes of it. Commonest, yes, you have to rule out the chromosomal cause. You have to look at the heart also, because many of the early cardiac anomalies, severe anomalies would lead to hydrops. And then there are skeletal dysplasias, genetic causes, infections, anemia, etc., etc. One by one, we have to rule out that first. So look at the structures, heart first, rule out those structure anomalies. Are there any markers of chromosomal anomalies? Increased NT would be there in this particular case. Are there any ductus? How is the ductus, tricuspid, nasal bone? So all markers we look at, try and find out. And then first thing would be, yes, a CVS to rule out the chromosomal cause, and explain to the patient. Counseling is extremely important that one by one we have to rule out the causes and try and find out, reach to the cause, and also look at follow up the case till the investigation comes with maybe within a week, 10 days, have a look at the fetus. There are some of the causes, suppose I'll just tell you about one parvo B19 infection. That's a cause wherein the hydrops develops, but it's a treatable cause. And with that one single intrauterine transfusion, you can treat it also. There's some treatable causes of hydrops as well. So we must first try and find out and reach to the cause and then counsel the patient. But the termination is, of course, not an answer. Because the minute you terminate, and if at all after your counseling and everything, patient is not ready financially and wants to terminate, as I said, always get a fetal tissue DNA storage or fetal tissue testing done, so that at least in next pregnancy you'll be able to help that patient. That is at least minimum we should do.
And ma'am, for the benefit of the viewers, this fetal DNA storage and the fetal DNA, the tissue sampling, is it expensive? Can the average patient afford it?
It is just costing 2,000 rupees or 2,500 in genetic lab. They'll store at least for minimum 2 to 3 years. So in between, before the patient plans next pregnancy, within maybe 6 months, 1 year, you can do genetic testing and help the patient.
That is such a fantastic message, madam, because you have given the message that whenever it's a wasted pregnancy, aborted pregnancy, even in a government or a private setup, you should store the fetal tissue so that her, the next pregnancy, she can work on that. Thank you so much, Bela ma'am, for the informative talk. And with permission from Sneha ma'am, can I move to the session 3, madam?
Yes, definitely. Please go.
So now I think we are all set to go to second trimester. And who would be better than Dr. Kuldeep Singh, who is also my teacher and mentor. Regards, sir, many regards. Dr. Kuldeep Singh, I would like to say from my side, has been instrumental in developing my skills in ultrasound and also, teaching others. I mean, he has taught so much that now we even dare to teach others. So Kuldeep Singh, sir, I'll always be indebted to you, sir, to chair his talk on pearls of second trimester scan. I have a very dear colleague from JIPMA, Dr. Professor Chitra.
I'll call you back 2 minutes. I'll call you back.
And we have Dr. Neha Varun from AIMS Delhi. So I'm grateful to Dr. Neha and Dr. Chitra for accepting our invitation on behalf of Dr. Sneha. I would like to introduce Dr. Chitra Tyagaraja from JIPMA, who is a fellow in reproductive medicine and minimal access surgery with a certification in advanced research methodology. She's working in JIPMA, which is again a very premier institute. It's the AIMS of South India. She has been awarded the Purnima Nadkarni Award in ISAR 2020 and Ashara Award in ISAR 2017. Shanta
Monica
ma'am,
we can keep it short. We can keep it short because we are running.
Okay.
Just introduction is more than enough.
Yeah, but Chitra, whatever your CV says, you are 100 times better person than your CV also.
Oh, thank you so much.
I do agree with you. We can go ahead.
And
welcome, Dr.
Chitra. Madam, I would like to just speak 2 lines about Dr. Neha Varun. She is a very active member of FOXY and AOGD. She has, worked very hard in the Family Welfare Committee. She's at present working very hard in the Medical Disorders Committee. I have listened to her talks. I've seen her work. She is a National Master Trainer of Implanon with several publications and awards, especially the Kamini Rao Oration Award. We are delighted to have you with us, Dr. Neha. And Chairperson, please introduce our speaker.
Thank you, Sneha ma'am and Monica ma'am, for giving us opportunity to chair the session. I really, indeed, it was very nice webinar. I mean, I've learned a lot of things. I mean, I'm not much anomalous and Bela, but man, seriously, nice to have so nice pics. So with the second time is ultrasound and with the Sir Kuldeep sir talking about pearls in the second time is anomaly scan, I think it is going to add a feather to all the people who are listening. So I welcome sir. Sir is a master trainer in his field of ultrasound and he is very passionate about. And he's also practices in New Delhi. He's also known for his skills in ultrasound, infertility, and he has more than 600 talks over national and international platforms. He has been invited for his academic experience in most national and international places, and he has received 4 awards and 3 gold medals in the field of ultrasound, and is also authored 6 books in ultrasound in obstetrics, gynecology, infertility. And sir, his books has been so good that it's been translated into Spanish, Chinese, and Portuguese also, and he has been awarded with Imaging Science Science Award in ASOG for in Delhi. So now he is successfully running Sona School, which organizes various training programs. So we are all waiting to listen to you. Over to you, sir, to tell us about pearls in second trimester ultrasound.
Thank you so much. I hope I'm audible.
Yes, sir. Yes, sir.
Perfect. I'll just share my screen. Is the screen visible?
Yes.
Yeah, sir. It's visible.
Yes.
Perfect. I'd like to thank Dr. Sneha ma'am for giving me this opportunity, and it's always a pleasure to be in a webinar where Monica is also there. So it's always, and she says such flowery words about me, and I feel so happy and bloated. Thank you so much. Thank you, Dr. Chitra. Thank you, Dr. Neha, as well for chairing the session. The seniors, Dr. Prashant, Dr. Alpesh, Dr. Pardesi sir, Dr. PK Shah is going to be now giving the talk after this. Dr. Bela, it's always a pleasure to be here. Dr. Archana ma'am as well. So I'm going to talk on it's not going to be an anomaly scan because we're not taking in from there. It's just going to be on pearls on second trimester scan as to what all are the things that one can see. It's not only just looking at the fetus, but a little around as well. That's what I'm going to be specifying. I hope the slides are moving and I'm audible. So
yes.
Yes, sir. Yes, sir.
Thank you so much. Wherever there's a hassle, do let me know. So it's going to be pearls of a second trimester scan, and we usually follow the principle of week full, week question you answer and learn, and that's going to be the flow of talk. I'm going to be talking on each and every aspect, and it's not going to be in very much detail. It's just so that it's a touch and go, so that we understand how to approach a second trimester scan. It's not always that when you are doing a scan, it's also if you're asking for one and somebody sent you a report, you should be able to understand it. So first we come on to is what are we looking at in an MAP? Morbidly adherent placenta, and we always need to remember forewarned is forearm. It's not always about the thinning of the retroplacental myometrium that's there. There are plenty of markers that we need to be following up. We need to be looking at the clear zone. This is normal clear zone. And if you're looking at a loss of clear zone, that's abnormal. Normal clear zone, abnormal clear zone. What I always say is if you're looking at an anterior placenta, a previous cesarean, somebody must have got other surgeries as well, like a myomectomy. But if we talk about the most important, this cesarean scars, number of cesarean scars, you're looking at an anterior placenta which refuses to move up. Think of MAP of placenta accretas unless and until proved otherwise. If you're looking at a loss of the clear zone, the hypoechoic retroplacental zone, not visible, and you can see it in 70% of cases. You could be looking at myometrial thinning, and if it's less than a millimeter or it becomes undetectable, this sign is there in around 50% of affected cases. Now, this is the most important thing, and that's placental lacunae. It's basically to assess the presence or the extent of lacunae, where various grades, which I'm not going to go into too much of details, but we have from grade 0 to grade 3, according to the Finberg's criteria. None of them seen 1 to 3, 4 to 6 larger, many throughout the placenta, some appearing large or irregular in shape. Switch on your color Doppler, switch on your power angio, and if you see flow within, we know we are in trouble. Few venous lakes here and there, few subchorial avillus areas is nothing to worry. You're looking at normal placenta, one odd, nothing to worry. If you're looking at these, especially the ones which are coming from the serosa, and if you see that there is a little flow in them, especially on a power angio, just switch in for a few seconds and close it, we know we're looking at trouble. Presence of intraplacental lacunae, first criterion to be associated with placenta accreta. Larger, more irregular, higher the frequency of placenta accreta. Seen in second and third trimesters, one of the most reliable data for diagnosing placenta accreta. You're looking at interruptions. This is smooth. If you're looking at interruptions, we know we're looking at trouble. The placenta is eaten all the way. You're looking at more thinning, myometrium undetectable, we're looking at trouble. Myometrial thinning, basically because of scar dehiscence, Not a very strong ultrasound marker as we used to believe. So we need to be watchful for looking in for the other markers. Because the scar adhesions more pronounced in the third trimester, when the lower uterine segment is further stretched, myometrium can become so thin that the placenta can be seen through it at times of delivery, and it's described as a uterine window, which you all must are much more aware of it when you do the deliveries, and it represents deficient myometrium rather than abnormal presentation. Invasive accreta, you're looking at irregular margins. In scar adhesions, the placental border is smooth and regular. You're looking at the placenta, it's quite low. That's the bladder over there. Placenta, even in the third trimester, down to the os we're looking at. And we're looking at the scar area, trying to see how much of a myometrium we're looking at over there. Are we looking at placental lacunae? Are we looking at any other features of an interruption as well? And what I've started doing now is, quite often I'm using my linear probe as well to make sure that we're not looking at trouble, especially for the scar thickness. This is a placenta which is going through and through. Complete placenta previa, where it's coming from one wall, across the internal os and going on the other side as well. If you're looking at a placental bulge, this is normal, smooth. If you're looking at a bulge, we know we're looking at trouble. Focal exophytic mass seen over there. You're looking at an increase in vascularity. We normally feel the subplacental area or the retroplacental area should be very, very vascular. No, this much of a vascularity is fine, but if you're seeing much more than that, it should increase an index of suspicion, raise an alarm button that you could be using for accretas as well. Increase in the vascularity. And especially you can see it in the posterior area. Somebody's got a myomectomy done. Somebody has a scar in the posterior myometrium. Always and always try and see this rather than straight away referring them for an MRI. If you're looking at the placental vessels over there, which are parallel to the serosa, it's fine. But if they're perpendicular, you again know you're looking at trouble there. On the 3D, you can again see plenty of vascularity. That's the whole idea, where you're trying to look at a lateral view and a coronal view over there. Now, these are basically the scoring systems. And if you see the lacunae over here, grade 3 and grade 2, 3.5 is the value, 1 is the value. More than 2 cesarean deliveries, 3 is the value. You're looking at myometrial thickness less than a millimeter, 1 to more than 3 millimeters, 0.5. 3 to 5, we're looking at 0.25. Anterior placenta previa, these are the values of the scoring. And then you're supposed to be adding them up. And once you add them up over here, is what you're going to be looking at, the probability of invasion. So if you're looking at a score of more than 6, chances of an invasion are more than 83%. So that's how you're going to be adding them up. So if you see more than 2 cesarean deliveries, plenty of lacunae, you're looking at 6.5. If you're looking at an anterior placenta previa, 7.5, and we know we're looking at more than a 90% chance that there's going to be a placental invasion and accreta. What are the indications when you need an MRI rather than asking an MRI for all of them? Because you need to be careful that the place that you're sending them for an MRI should be apt for doing obstetric MRIs as well. So the indications are, if you look at a posteriorly implanted placenta, visualization of lateral walls is required. To look for bladder invasion when the ultrasound findings are unclear or there's uterine bulging into the bladder. And we should be careful, do it meticulously, and you would not be needing an MRI so frequently. Looking at Leica amnion, the same thing that we're doing for our NTs and for measuring crown rump lengths, we need to be carefully knowing the technique for how to measure the Leica amnion. We could be doing it with the deepest vertical pocket, which is now mostly done, or you can still have your amniotic fluid index. Irrespective of which way are you doing it, you need to be watchful that your transducer has to be perpendicular to the obstetric table, parallel to the midline. The deepest vertical pocket has to be taken, excluding the limbs and the umbilical cord, and you can either add them up or looking for the deepest vertical pocket, only single pocket. It has to be perpendicular, not oblique. Do not apply pressure on the maternal abdomen. Please exclude the umbilical cord. Whenever in doubt, switch your Doppler box, your color box over there. You're looking at, basically, that's the Leica that you're going to be looking at. If you're looking at less Leica oligohydramnios, or you're looking at more polyhydramnios, but again, be careful that you're not looking at an amniotic band. The moment you're looking at an amniotic band, be careful that you're not looking at any amputation defects, you're not looking at any slash defect on the abdominal wall or on the fetal lips or the face. And do mention where are you looking at the amniotic band, make sure how thick it is so that it's not like a fibrous band, just an amniotic band. And make sure that next time if anybody else is doing it, they should know where is to see it, and all these things have to be seen again. You can have the various charts where you can look at the Felon's classification of whichever chart you're using for to see for whether it's oligohydramnios, polyhydramnios, or normal light. Single deepest vertical pocket, less than 2 centimeters oligo, more than 8 poly, normal is 2 to 8 centimeters or 20 to 80 millimeters. You're looking at oligohydramnios, looking for FGRs, looking for renal abnormalities. You're looking at polyhydramnios, looking for neural tube defects, looking for the, basically, if there's any GDM or not. You need to be looking in for the GI anomalies for polyhydramnios. The proximal the anomaly of the GI, the earlier the polyhydramnios will be, the severe the polyhydramnios will be. You're supposed to be looking for umbilical cord, especially the number of vessels. And the moment you see a single umbilical cord, a single umbilical artery, SUA, or a double vessel cord, don't jump on that you're looking at major problems. You just have to be seeing the baby completely from top of the head to the toes that you're not looking at trouble. You're looking at the umbilical cord, you can easily get your color box onto the fetal urinary bladder so that you're sure of that you're looking at 2 hypergastric arteries. The blue and the red indicates flow towards or away from the transducer. Urinary bladder, and you're looking at both the hypergastric arteries, and they're going to form the umbilical arteries. The 2 hypergastric arteries. Whenever in doubt, take this. Because of coiling, sometimes you can get a little confused. And whenever you're looking at a double vessel cord or a single umbilical artery, usually the coiling is not that much. So you can see a stretch where you can only see 2 vessels over there. This is the artery because you can see the fluctuation here, and this is smooth over there. Single hypogastric artery, single umbilical artery seen over there. When you're looking at a single umbilical artery, it increases the chances of almost 7 times for the anomalies and more than 15 times for chromosomal abnormalities. But nowhere does it say that there has to be a problem. Looking for anomalies, especially the genitourinary, the cardiovascular, and the musculoskeletal area, and we're going to be seeing them. We now see a single umbilical artery quite often, and we're not worried about it anymore, what we used to be 20 years ago. The moment you're looking at twin pregnancies, the ones that have been diagnosed from the early pregnancy, from the NT scans, but you need to be carefully watching them for anomalies. If you're looking at fetal and neonatal mortality, it can increase 3 to 6 times than that of a single pregnancy. Neonatal mortality, 7 times than that of a single pregnancy. Higher incidence of premature labor, and therefore the rest of the sequelae. The risk of complications depends on the chorionicity. Di-di, 10%. Mono-di, 20%. And when you're looking at a mono-mono or a momo twins, more than 50% chances you need to be watchful. A dichorionic diamniotic, the complications could be FGR. There could be other ones or placenta-related problems as well. That's the twin peak sign. We know that we're looking at two placentas. If we're looking at anterior posterior wall, right or left wall, there is no hassle at all. But if they're both on the same wall, we need to be carefully seeing. We have a thick membrane, we have a bit of placental tissue coming inside. That's the lambda sign or the twin peak sign. When we're looking at a monochorionic diamniotic or a monochorionic monoamniotic, you need to be figuring out it's a single gestational sac, how many yolk sacs? Later on, are we looking at a thin intertwin membrane? And we know there's going to be a single placental mass. The T sign of it. We're looking at something perpendicular. We know it's a single placental mass, but we're looking at two amniotic sacs. The various problems because of placental vascular anastomosis, twin-twin transfusion, twin embolization, the trap sequence, twin reversed arterial perfusion. There could be a demise of one twin, and then it's associated with an adverse outcome. Placental insertion-related problems, filamentous cord, marginal cord insertion. We come on to the next thing, which you can start off quite early, is if you're looking at an Rh negative mother, an Rh positive father, looking for anemia. And we need to be looking at the middle cerebral artery. The middle cerebral artery to figure out about what are we looking at in terms of the peak systolic velocity. The end diastolic flow is used for looking for brain sparing effect. We're looking at the circle of Willis, and that's the middle cerebral artery. Insonate that, and normally it's the anterior cerebral artery which is much more sensitive, but we cannot use it because that's going to be at 90 degrees and that's not going to show color. So that's why less than 30 degrees as the insonation and the middle cerebral artery does the trick for us. You need to enlarge the circle of Willis, image the whole vessel, align the vessel parallel to it, measure close to the exit point, avoid measuring during fetal breathing, hiccups, or movements. That's the sample volume which you're going to be putting up at the point of origin. Now we know over there that the sensitivity of the PSV is there for the prediction of moderate anemia, where we have a hemoglobin concentration of less than 0.65, severe anemia less than 0.55. And we know in fetuses without high drops, it's 100% or quite high, with a false positive rate of 12%. Risk of anemia high in fetuses with a peak systolic velocity of more than 1.5 moles. Below 1.5, they either do not have anemia or mild anemia, which you're not worried about, and that's not clinically important. You need to have your angles correct, and we're going to be measuring the peak systolic velocity. Next comes to the diagnosis of structural anomalies. You know, we're looking at a major anomaly, or are we looking at a minor anomaly? How much importance to be given to either of them? You're looking at a major anomaly with an impact on medical, surgical, cosmetic importance, impact on morbidity and mortality. Minor anomaly does not have serious surgical, medical, or cosmetic significance, does not affect normal life expectancy or lifestyle. Major anomalies is 2%, minor anomalies is 14%. Now, but still the minor anomalies are important. They can serve as indicators of altered morphogenesis and more serious defects. You've discovered an anomaly, what next has to be done. That's most important because that's the question the patient is going to be asking. So you need to figure out, is this anomaly isolated? Is it a major anomaly with an associated minor or another major anomaly? It's a minor anomaly with associated another minor anomaly. And does it have any association with aneuploidies or syndromes? So the moment you're looking at anatomic defects, it's going to raise the suspicion of more complex set of anomalies. The moment you see one, don't stop there. You're supposed to be looking for what all are the other systems, or in the same system, what all am I supposed to be looking at? So you see a lemon-shaped head. You know it's associated with spina bifida, and AVSD, major cardiac anomaly associated with Down syndrome. You're looking at the lemon sign over there. You're looking at the dangling choroid plexus over there. You know you're sure of. If you're not seeing the posterior cranial fossa correctly or nicely, you're supposed to be looking at the spine definitely over there. Not that you're not going to see the spine otherwise, but then it has to be with a proper microscopic eyes that you're going to be looking at. AVSD seen over there. You're looking at a VSD. The moment you see anomalies like this, you're supposed to be looking at what are the other anomalies, because that's going to have a bearing on the prognosis. What all aneuploidy should I be looking at, and what am I going to be getting it checked? There's a burden of anomalies to the parents, to the society. So it's implications for healthcare resources. If you're looking at something which is lethal, it will not place as large a burden on the healthcare system as with the birth of a baby with a condition associated with possible survival and long-term handicap. We know if it's a lethal one, there is going to be bound to be bad news. But if you're looking at a long-term handicap, it's definitely going to be troublesome for the parents as well. Following issues need to be considered: performance of a prenatal diagnosis, workup of an abnormal finding, site, mode, and timing of delivery. The spectrum of the disease, implications, possibility of genetic syndromes always has to be kept in mind. Am I looking for something like trisomy 18, Meikle-Gruber syndrome? Because that's going to be what next? What am I getting the parents checked for? What do I think about the next pregnancy as well? One of every 5 newborns could be affected with a birth defect. Identification of any anomaly in a fetus must prompt a careful search for other anomalies. Wherever needed, or in fact, the moment you see an anomaly, definitely get a fetal echocardiography done. Wherever needed, also get a fetal karyotype done as well, because that's going to be detrimental. What's good is now we have till 24 weeks, so the window is increased. We can look in for cardiac abnormalities with much more ease. Our machines are getting smarter, we're getting smarter. If you're looking at a serious anomaly, we need to be delivering it at a place where we have 10 ICU facilities. You're looking at an anomaly which is ductal dependent cardiac lesion. Abdominal wall defects may benefit from maternal transport and delivery. It's not easy to transfer the baby. It's much more easier for the baby to be inside mama's tummy and transport the mama there, get the delivery done at a tertiary center. Some anomalies can alter the method of delivery. Conjoined twins, giant omphalocele, large sacrococcygeal teratomas, severe hydrocephalus, you need to be watchful how to deliver them. The delivery of an infant with a congenital anomaly should ideally occur at term. So we need to be just prolonging as to how much. A surgical corrective procedure should be delayed because if we're looking at respiratory distress or any other problems of prematurity. So earlier delivery can cause an increase in such problems. You're looking at a thick nuchal skin fold. You're looking at an AVSD over there. You're looking over pylectasis over there as well. You're definitely thinking of trisomy 21. So you need to be, and as the previous speakers, Dr. Bela and the others have also said, counseling is very important. How do you prognosticate structural anomalies? Termination is not the end of everything, because that's the first thing to jump from a ship the moment you're looking at trouble. but always and always see what has to be, because there's nothing like a precious pregnancy. For a mother, each and every baby is precious, and you need to be asking them, explaining them in detail. You're looking at a problem over there, spina bifida. You're looking at ventriculomegaly. You're looking at an osseous spur over there. You're looking at a kyphoscoliotic deformity. You need to be explaining them what anomaly, how is it going to land up, what are the chances. You're looking at a cystic adenomatoid malformation. You're looking at a cystic adenomatoid malformation over there. You need to be watchful. How much is the mediastinal shift over there? Am I looking at any hydrops? And then you always have this lovely formula looking at the CVR, congenital pulmonary airway malformation. And you can easily calculate the CPAM volume divided by the head circumference. And it's a computer which is going to tell us about the prognosis. These can really look dangerous. Up to 24 weeks, they increase in size. And from 26 onwards, they start reducing, to the effect that sometimes after delivery, you don't see them at all. Unless and until you're looking at quite a large cyst, you need to be prognosticating them a little differently. You're looking at a diaphragmatic hernia. That's the stomach seen in the retrocardiac area, in the thorax over there. Again, we have a lovely formula, DLHR, the lung-head ratio, where you're going to be looking at, if it's a left-sided one, a left-sided diaphragmatic hernia, on a 4-chamber view, looking at the right lung, measure the 2 dimensions, divided by the head circumference. 100% survival in LHR more than 1.3. 0% if it's less than 0.6, and that's what you're going to be telling the patient as well. Looking at markers of aneuploidies. Minor anomalies may carry a higher risk of chromosomal disorders. They're collectively called as markers. They have a relationship to aneuploidy. Unlikely to be clinically significant, but if they have it to aneuploidy, you need to be excluding that. They are, as compared to structural anomalies, they are transient, non-specific findings, and can also occur frequently in euploid fetuses. That's why I specifically said also, and that's why I've emphasized on euploid. The moment you see something, don't jump up, there is a problem. Most common, that's the list. EIF, choroid plexuses, long bones, shortened long bones, hyperechoic bowel, echogenic bowel, NSF. You're looking at a choroid plexus cyst. Straight away doesn't mean you're looking at trisomy 18. If it's isolated, we know we're not in that much of a trouble, and we should not be worried about them, whether they're unilateral, bilateral, single, multiple. You're looking at an absent nasal bone. I'm not saying you're not going to be thinking about them. You're going to be thinking about, you need to scientifically look onto them and decide. Absent nasal bone. You're looking at echogenic intracardiac focus, 2 of them in the left ventricle. You're looking at echogenic bowel. Make sure it's more echogenic than the bone. And you're looking at echogenic bowel. Few markers have a strong association with chromosomal anomalies and would require karyotyping. Other markers can be very common, not associated if they're isolated with any handicap. Do not carry a high risk for chromosomal anomalies. If they're isolated, you're not supposed to be worried about them. Naivagan colleagues have done this, and they were looking at hyperechoic bowel, shortened femur, shortened humerus, EIF, renal pylectasis. I'm going to show you the chart just now. As an isolated finding, nuchal fold thickness, if it's more thickened, has a highest likelihood ratio. Short humerus has the next highest likelihood ratio. Nowadays, we're working on so much of aberrant right subclavian artery, that also has a higher one. Femoral length pylectasis still have a little higher, than EIF. EIF has a low likelihood ratio. Presence of a thick nuchal, structural anomaly, major ones, short humerus, sufficient to exceed the commonly accepted threshold for offering karyotype. If there's more than one abnormal finding on ultrasound, patient older than 35 years of age, or if the multiple marker screen is abnormal, amniocentesis should be recommended. The low risk ones, if you're looking at a choroid plexus cyst and EIF, you're not getting worried about it. Don't worry and don't let the patient panic about it. Choroid plexus cyst, make sure it's nice, clear, and round so that there's no confusion. This is inspission. This is not a choroid plexus cyst. Be careful. This one is fine, not on the other side. Irregular. Again, major structural anomalies like a high skin fold or a thick one, definitely you need to be watchful. That's the chart we all follow to look in for whether there's EIF, ventricular megaly, thick NSF, echogenic bowel, mild hydronephrosis of pylectasis, short humerus, short femur, ARSA, absent or hyperplastic nasal bone. Depending on what all features, we keep multiplying and looking at increasing the risk. This portion, sir, is Dr. B.K. Shah is going to be covering up. I'm just going to show you 2 or 3 slides on the PH and FGR. We need to be looking at the uterine arteries very carefully, even in your anomaly scan, because there could be features for showing early preeclampsia, preterm preeclampsia, or late preeclampsia. And you can have indices for detecting or a Doppler sensitivity for predicting FGR as high as 58%. That's a prediction of preeclampsia by uterine arteries. 96%, 80%, 44%. We've done a trick on the NT scan, and we're supposed to be looking at the anomaly scan as well. Normal uterine artery Doppler do not require serial measurements of fetal size. They will not be developing specific pregnancy complications. If you're looking at abnormal uterine artery Doppler at 20 weeks, 24 weeks, if you're looking at a PI more than the 95th percentile, that was there in the first trimester as well, whether the aspirin has been started or not, but you're supposed to be looking at serial ultrasound measurements of fetal size, assessing umbilical artery, ductus stenosus, middle cerebral artery to see for early or late FGR. So you have to be putting it up in your notes so that we can start working on them from 26 to 28 weeks. So what you're doing in an anomaly scan, you're screening for lethal anomalies. Keen in carefully, bilateral renal agenesis, thanatophoric dwarfism. High morbidity, long-term handicap, NTD, cardiac anomalies, aneuploidies. Anyone requiring intrauterine therapy, twin transfusion, RH negative, requiring a postnatal investigation, a renal or a facial cleft, and counseling and parental preparation definitely needed. If you're looking at an acrania, we know we'll not be able to help them out. It's a lethal anomaly, but we still need to be breaking the news gradually to the parents. So friends, we need to be looking at, I didn't only talk about anomalies specifically because that can be for a whole day, we can have a webinar, but it's just that do not only look for anomalies, how to approach them and how to see for the fetal environment is necessary, and you can do a world of good to the patients and to yourself as well. Thank you so much.
Would the chairpersons like to conclude the talk?
Thank you, Kuldeep sir. It's always a pleasure listening to you.
You're muted, Dr. Neha.
Hello, am I audible?
Yeah,
yes, now you are.
Yeah, it is always a pleasure listening to you, sir. It's a wonderful talk. And actually, it is very important to understand the basic things first and then go on to the complex things, which I feel being in a institute, working in an institute, because we don't understand the importance of the basic things we need to see in the ultrasounds, and we jump on, the complex things. And counseling is very important. we need to understand that whatever we are doing, we need to counsel the patients, and that's a very important thing. And it usually affects, their mentality also and their emotional this thing also. Thank you so much.
Thank you, Dr. Neha.
Thank you, Dr.
Thank-
Sneha, Dr. Monica, for inviting me for this wonderful webinar, and chairing this session is actually a this thing for me. Thank you.
Thank
It
you,
was
Kuldeep
great
sir.
having you.
I think it was really good. I mean, even the persons who are not well-trained ultrasoundologists, you gave some points which they see abdominal can pick up and better refer to this thing. Like even I have learned a lot of things where you have to do that. I've never heard of that uterocervical, vascularity. So these are the things which we can pick up. Thank you for this wonderful talk, sir.
Thank you. Thank you.
Thank you, chairpersons. Thank you, Kuldeep sir. And now we move to the last session, that is session 4. And this is a very great session by a very great teacher and speakers. He is a teacher of teachers, Dr. P.K. Shah sir, past president FOXI, and he will be speaking on FGR. To chair this session, I invite Dr. Pramila Modi madam, who is past president Patna OBGYN Society, and Dr. Amita Sinha. Can I have the series, please? Dr. Pramila Modi, welcome, madam. Madam is a senior OBGYN practicing in Modi Nursing Home, Patna. She has had several important key posts in conferences like AICOG Patna 2014, and she's been the past president of Patna OBGYN Society, ISOPA past contributor and executive member, past chairperson in Akhil Bharatiya Marwari Sammelan. Madam has had number of publications in national and international journals, contributed chapters in various books of FOXI, and prepared several informative booklets for patients both in English and Hindi. These deal with pregnancy care, safe motherhood, contraception, nutrition, and menopause. She has been awarded the Ethicon Traveling Fellowship of FOXI in 1977, as way back in 1977, and the recipient of Jagdishwari Mishra Award and Lifetime Achievement Award by POGS. Welcome, madam. We are honored to have you as chairperson today. Next, I would like to invite Dr. Amita Sinha, another very senior gynecologist from Patna. Madam is the secretary of Patna OBGYN Society, communicator ISOPAP, E-Zone coordinator of the Practical Obstetrics Committee of FOXI, governing council member of AOG SBJ, and organizing secretary of FOXI PPHCOM. Madam has been the recipient of FOXI Padma Bhushan Kamlabai Hospital Award. She has published several books and is a life member of important organizations in India. Welcome, chairperson. Kindly introduce our speaker.
Good evening, everyone. Respected, am I audible?
Yes, ma'am.
Yeah. Respected Dr. Sneha Buyar, respected Dr. P.K. Shah, whom I know very well. Very recently, he had been to Patna, and we were so happy about it. Dr. Alpesh Gandhi, our past president, all the dignitaries, viewers of this beautiful, I should say a wonderful webinar, and all the viewers. Professor P.K. Shah is to be introduced by me. It is difficult. You know why? Because it is such a long introduction, which I tried to make it small, but sorry, I could not make that much. But be patient. This is the last event of today's webinar, and one must know how a person can achieve a height. Professor Unit and head of the Department of OBGYN at LTM Medical College, LTMG Hospital, SETGS Medical College, KEM Hospital, Mumbai. Past president of FOXI, IAGE, MOGS, and others. Past dean of Indian College of Medical Ultrasound. Past chairman of Imaging Science Committee, FOXI.
That's enough.
Yes?
That is enough.
No, sir, that is really not enough, sir. Let me speak few things. Okay, I'll make it still
One or two lines.
Okay. He is a recipient of Lifetime Achievement Awards by many And the most important thing I would like to spell about is he is the first recipient of Young Gynecologist Award of Asia Oceania, and he has many contributions in ultrasonography. And I must tell you, he had delivered 39 orations, more than 700 lectures in local, state, and national, international conferences. And Best Committee Award from Foxy by Mehru and Sutia's Award. Last but not the least, Dr. Shah is very methodical and an excellent orator. He is very friendly to many Foxians, and particularly I take this privilege to say we members of the Patna Obstetric and Gynecological Society. May God bless you, sir, with health and wisdom.
Thank you very much.
He is a true Foxian. Thank you very much.
Thank you very much, ma'am, for kind introduction. I think it was nice meeting you all at Patna.
Yes, sir. Sir, can I say something?
Please.
Yeah, I must thank Sneha for inviting me to this big event, I should say. I would have missed so many things, Sneha. Thank you very much. I have 3 things to tell you. Number 1 is thanking for calling me. Congratulations for organizing this beautiful webinar, and wish you all the best in future. Thank you.
So much. Thank you so much, madam, for your blessings always. Thank you so much. And I'm very happy to have sir as the speaker for our program today. So over to you, sir.
Yes, sir.
Yeah. So thank you much. Thank you very much, Sneha, for giving this opportunity to me to talk to you all on fetal growth restriction. I'm sure all of you know fully well that the whole thing that we used to talk about IUGR is given up, and now we only talk about fetal growth restriction. I think you all know very well the causes of fetal growth restriction: fetal, placental, and maternal. So I'm not going to go into details of, but there are causes of placental insufficiency, a working list that includes maternal hypertension, maternal thrombophilic disorders, APLA, chronic nephritis, SLE, diabetic microangiopathy, postpartum pregnancy, etc., etc. Fetal growth is a result of maternal availability of nutrients, placental transfer, and fetus's own growth potential. In fetal growth restriction, the fetus doesn't succeed to reach its own growth potential. When do you call it as small for gestational age? When the birth weight is less than 10 percentile. There are 2 things. One you have to keep in mind is genetically small, who are constitutionally small fetuses. Like if a woman is 40 kg, she's not going to deliver 4 kg child at term. She will hardly 2.2 kg full-term baby. But they are healthy small for gestational age when they are genetically small, and the Doppler will be absolutely normal. Whereas in fetal growth restriction, we all know that it's a failure to achieve growth potential. And as Indians, we are small, and small Indians have small babies. 50 to 70% of small for gestational age fetuses are constitutionally small, whereas 30% are fetal growth restriction. Constitutionally small, the perinatal outcome is normal. There are no IUFDs normally, no signs of adaptation. Whereas in FGR, you have poor perinatal outcome, IUFD, signs of adaptation on Doppler. Not all SGAs are growth restricted. Not all FGRs have birth weight below 10 percentile, and even 10% of AGA fetuses may be FGR. So what is the definition? Estimated weight less than 10 percentile as given by ACOG, RCOG, based on various parameters like BP, AC, etc., or WHO has given a definition that if the estimated fetal weight is less than third percentile, straight we will call it as fetal growth restriction. And we all know that it's the commonest cause of premature birth and intrapartum asphyxia. But there is an extended definition of fetal growth restriction, which should include these three parameters. One, estimated fetal weight less than third percentile, CPR less than 5th percentile, and uterine artery PI more than 95th percentile. So FGR is estimated fetal weight less than 10 percentile plus any one of these three above that I have shown you. Overall incidence is 6 to 8%. It's responsible for almost 50% of perinatal mortality. When it comes to pathophysiology of uteroplacental causes, it's an absent physiological changes in some segments of spiral arteries, whereby the spiral arteries do not penetrate into the adventitia of the trophoblast doesn't penetrate into the adventitia of the spiral arteries and doesn't cause dilatation. So what is the pathophysiology in short? Inadequate trophoblastic invasion, absence of uterine artery vasodilatation, reduced placental perfusion, hampered villus microcirculation, umbilical hypoxemia, and vascular changes for compensation. Growth restricted fetuses have an augmented risk of mortality and morbidity due to intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, infections, pulmonary hemorrhage, hypothermia, and hypoglycemia. So when you have weight less than 10 percentile with an increased HCAC ratio, keep in mind that probably you're looking at a FGR fetus. What is important is evaluation of the fetal weight has to be done by ultrasonography. So ultrasound evaluation of fetal growth restriction, steps in appropriate evaluation and assign fetal age, assess fetal size, estimate fetal weight, do amniotic fluid assessment, color Doppler biophysical profile, and rule out congenital anomalies. So FGR in placental dysfunction, what do we monitor? To monitor growth, your biometry, BPD, HC, etc., and growth charts. And you have to chart them on the growth charts. Fetal compensatory mechanisms, predicting hypoxia and acidemia, you have to use Doppler. And for environment, you have to use either CTG, AFI, biophysical profile, and look at the placenta. We all know that we used to do once upon a time clinical evaluation by serial measurement of symphysiofundal height, abdominal girth, etc. And fundal height increases by 1 centimeter per week between 40 to 32 weeks. If there is a lag in fundal height by 2 weeks, moderate FGR. If it is more than 4 weeks, severe FGR. Unfortunately, it has got very low sensitivity and hence it should not be used in practice. So how do you establish gestational age? By first trimester crown rump length, if it is available, is the most accurate means of dating the pregnancy. And we all know how to take the crown rump length. I will not go into the details of. Now, you have to do proper sonographic evaluation of fetal biometry. That includes fetal biparietal diameter, head circumference, transverse cerebellar diameter, abdominal circumference, femoral length, and measurement ratios. Alteration of placentation has an important impact upon fetal growth, the most affected being abdominal circumference, all of you know that, whereas biparietal diameter and femoral length are less modified. Comparison with standard growing curves and calculation of percentile is important. Serial evaluation of fetus and calculation of individual growth curves. Dynamic evaluation of the fetal growth should show you the trend, and identification of a slowing or stopping of growth should give you suspicion. Do not diagnose fetal growth restriction on single ultrasound parameter. You have to have serial evaluation of the fetal biometry, and you have to chart them so that you get a correct idea about whether you're looking at fetal growth restricted baby or not. Measurement ratios are equally important. If you have HCAC ratio more than 2 standard deviation above the mean, it is predictive of growth restriction. And FL by AC about 23.5% please consider this as abnormal. Color Doppler detects deterioration of fetus at least 10 to 15 days before modalities available to us that can detect intrauterine fetal distress like cardiotopography, fetal biophysical profile score, etc. So by color Doppler, we try to find out the cause, whereas CTG, fetal biophysical profile, detect the effect. So what is the role of Doppler in FGR? To identify etiology, whether it is placental or non-placental, to identify hypoxia and fetal adaptation. And that will help you plan timing of delivery and to identify fetus is at risk of perinatal complications. Doppler is used to identify vascular bed resistance of uterine artery, umbilical artery. To identify fetal adaptation, you use middle cerebral artery. To identify cardiac decompensation, you use ductus venosus and umbilical vein. Uterine artery Doppler is very useful for prediction of fetal growth restriction. If the likelihood ratio of uterine artery Doppler is, if it is abnormal, fetal growth restriction likelihood is 3.7 times. Preeclampsia likelihood ratio is 5 times, and perinatal death likelihood ratio is 2.4. Whereas if it is normal, it is 0.7, 0.5, and 0.8 respectively. That is a normal uterine artery in first trimester. Please remember, you have to take PI and see that it is less than 2.5. The notch is no more considered nowadays, which we used to once upon a time consider. As the pregnancy advances, you go to the second trimester, there is increase in the end diastolic flow, and it keeps increasing till third trimester when you see so much of flow at the end of the diastole. SOGC clinical practice guidelines that the uterine artery Doppler may be performed at any time of 17 to 22 weeks in women with following risk factors. And you all know the risk factors like previous early onset gestational hypertension, abruption, growth restriction, stillbirth, pre-existing hypertension, gestational hypertension, etc. Pre-diastolic notch in uterine artery should disappear by 22 weeks of gestation. Unfortunately, the persistent notch has no significance now. What is important is middle cerebral artery PI divided by umbilical artery PI is the best indicator. What we call a cerebroplacental ratio, the single most sensitive parameter for assessment of fetal growth restriction, and has a single cutoff value of 1. Uterine artery Doppler is important at 20 weeks. Umbilical artery, MCA, aorta, and ductus venosus after 30 weeks. And ductus venosus is equally important between 11 to 14 weeks to pick up congenital anomalies and aneuploidies. Resistance in umbilical artery should decrease with gestational age, whereas the resistance of MCA should increase with gestational age, and the resistance of ductus should decrease with gestational age, whereas MCA flow resistance should increase with gestational age. If it decreases, that means there is a luxurious perfusion by which you know that there is a brain sparing. Eventually, there is a diastolic flow reversal in middle cerebral artery, and that tells you indirectly that there is cerebral edema and immediate action has to be taken. Fetal aorta flow resistance should decrease with gestation. In FGR, with compensation, there is less flow to the aorta because of high resistance. What does that mean? That less flow of blood to the kidneys, decreased glomerular filtration rate, and that leads to oligohydramnios. Less flow to coronaries and abdominal viscera, and that leads to fetal origin of adult diseases. Ductus has 3 forward waves, reversal of third wave, that is atrial contraction wave, immediate action has to be taken. Reversal of third wave in first trimester tells you that there is probability of chromosomal anomaly. That's a normal M-shaped ductus venosus. And when you have a reversal of atrial contraction wave like this, you know there is something abnormal. Now, there are 2 types of fetal growth restriction: early onset and late onset. And this is by the moment of onset, evolution, Doppler parameter modification, and postnatal outcome. The best cutoff between early and late onset is 32 weeks in terms of perinatal outcome. Now, there is something called as the Delphi's consensus for early FGR. Gestation age less than 32 weeks, no congenital anomalies, AC divided by estimated fetal weight or estimated fetal weight less than third percentile, the umbilical artery will show you absent end-diastolic flow. Or abdominal circumference or estimated fetal weight less than 10 percentile combined with uterine artery PI more than 95th percentile or umbilical artery more than 95th percentile. Whereas for late FGR, the Delhi consensus says that the gestation age should be more than 32 weeks. In absence of congenital anomalies, AC or EFW should be less than third percentile, and at least 2 out of 3 of the following, like AC, EFW less than 10 percentile, AC, EFW crossing centiles, CPR less than 5th percentile, or umbilical artery PI more than 95th percentile. Early onset IOGR is determined by massive lesions or dysfunctions of placental structure taking place during first and second trimesters of pregnancy due to inappropriate trophoblastic invasion of the spiral arteries. So in early FGR is considered to be a vascular disorder due to abnormalities of the tersally venous vessels. It is more frequently encountered in patients with preeclampsia, autoimmune disorders, or other conditions that can affect the placental vessels. Whereas in late FGR, it is not connected with preeclampsia. Please remember that. In this type of early FGR, the evolution is long enough to permit development of a classic fetal asymmetrical hypertrophy that can be diagnosed by ultrasound. This long evolution is mainly due to small oxygen demands of the fetal brain and to a long resistance to hypoxia of the fetal heart at this stage of gestation, when you talk about early onset IOGR. So what is the physiopathology? Reduced transfer of oxygen and nutrients towards the fetus, blood flow redirected towards vital organs, brain, heart, suprarenal, and reduced blood flow to muscles, bowel, liver, and kidneys. So there is a sequence of changes in progressive Doppler alteration in EFGR. There is abnormal blood flow in placenta due to vascular lesions. Increased resistance in the umbilical arteries determines the peripheral fetal vasoconstriction, augmented umbilical artery pulsatility index, cerebral vasodilatation with reduction of middle cerebral artery pulsatility index. Then comes absent end-diastolic flow or reversal of end-diastolic flow in umbilical artery, abnormalities in aortic outflow tract and cardiac insufficiency. There is overload of precordial venous system with atrial wave or third wave of ductus venosus absent or removed. That's a normal umbilical artery flow that I showed you earlier on. This is an increased resistance because there had not much of a flow, and still the PI is 1.45. Now this is absent end-diastolic flow, and this is the reversal of end-diastolic flow when you do Doppler. Same thing, reversal of end-diastolic flow. So what is the predictive value of umbilical artery waveform and indices? If impedance is increased in umbilical artery, 60% of the placental vascular bed is obliterated. Absent end-diastolic flow and reversal of end-diastolic flow are associated 40 to 70% perinatal mortality, respectively. That's a middle cerebral artery. It shows you always high resistance normally. If you see end-diastolic flow showing you so much of blood flowing, that means there is decreased resistance and PI around 0.94. You know that there is a profuse perfusion through the middle cerebral artery, which is going to the brain. And that tells you that there is a compensatory mechanism. Middle cerebral artery, PI less than 5th percentile, is an efficient tool for evaluation of cerebral vasodilatation. CPR less than 1, regardless, the evaluation method is associated with a poor perinatal outcome. So in early FGR, there is umbilical artery high PI, and in middle cerebral artery, there is low PI. Okay, please remember this. CPR should be considered as an assessment tool in fetuses undergoing third trimester exam, regardless of finding of umbilical artery and middle cerebral artery Doppler. It is a must that you calculate cerebroplacental ratio. There are discussions about utility of routine third trimester Doppler. Akolekar was from Sahan Hospital in our department, and I met him many times, and he says that third trimester ultrasound is very, very important to pick up late onset IUGR. And not only that, you must always combine it with color Doppler routinely. That's a ductus venosus normally seen, and that's a normal ductus venosus, and that's a reversal of A wave or reversal of third wave or reversal of atrial contraction wave. Okay, that's a systolic, and that's a diastolic wave, and that's atrial contraction wave. Ductus venosus flow Doppler is a useful parameter since all the precordial veins, the ductus venosus allows most accurate interpretation of fetal cardiac function as well as myocardial hemodynamics. Normally, we don't take only aorta, but we go for aortic isthmus PI. If it is increased and absolute velocities, especially 10xv, are reducing intrauterine growth restriction. Please remember, normally also it is like that, but when it depends further, you know that it could be because of growth restriction. So what is the timeline for fetal hypoxemia? You have abnormal fetal growth, you will find abnormal arterial Doppler. Within 2 weeks' time, you will find abnormal venous Doppler. Within a day or two, you will find abnormal cardiotopograph or biophysical file scoring. Coming to late onset IUGR, it represents failure of the fetus to reach growth potential at term. In most cases, the placental lesions have a late onset and or do not have significant extent in order to increase the resistivity of the placenta and translate it into augmented umbilical PI. The lesion is not so great or so severe that it would reflect into PI of umbilical artery in late onset. Late onset frequency is much more compared to early onset FGR. It is where placental abnormalities such as villus immaturity with less impact upon placental resistance. Therefore, the umbilical artery Doppler indices can be unaffected. Diagnosis is more difficult of late IUGR due to large variability of fetal parameters on growth charts in third trimester. Fetuses with LFGR estimated fetal weight appears to remain within the limits of AGA fetuses at more than 10 percentile. Please remember that. So LFGR can be suspected when individual growth curve slows down or either becomes flat, and an increase of HCAC ratio is detected in a previously normal HCAC ratio and normally growing fetus. Fetal brain at term has increased requirement of oxygen. Therefore, the first hemodynamic alteration in presence of hypoxia is cerebral vasodilatation. This method of neuroprotection cannot completely compensate the effect of hypoxia. The cardiac insufficiency does not have enough time to arise. Severity of the cerebral lesion taking place faster and determining severe CTG alteration. Therefore, the classical sequences of Doppler modifications that you see in early onset IUGR are not present in late onset IUGR. During the last 20 weeks, the brain increases in size by 17 folds. LFGR fetuses are very fragile due to increased oxygen requirement of their brain. They present multiple risks due to their inability to tolerate hypoxia. Reactive cerebral redistribution in late onset IUGR fetus is associated with an alteration in brain metabolism. Now remember this slide is very important. Undetected fetal growth restriction in third trimester of pregnancy represents the main cause of unexplained stillbirth in low-risk pregnancies. Undetected FGR. Also, probably a number of idiopathic cases of so-called cerebral neonatal palsy, where an acute intrapartum hypoxic event could not be identified, are in fact caused by undetected late onset growth restriction. Doppler markers of cerebral vasodilation seem to be a landmark of late onset FGR. MCAPI less than 5 percentile is considered a marker for vasodilation even in presence of normal umbilical artery Doppler. If in the third trimester, obstetrician analyzes only the umbilical artery PI, these fetuses, the early onset FGR, will be missed, and the potential intrapartum and postnatal complication cannot be anticipated. So early FGR fetuses are at higher risk of cardiovascular diseases, hypertension, glucose intolerance, diabetes, dyslipidemia, obesity in childhood and in adulthood. The ratio of these various numbers of emergency C-sections are seen in these cases, and LFGR fetuses cerebral redistribution are significantly increased. Please remember that. Recent guidelines recommend delivery of FGR fetuses with brain sparing effect because it is predictive of acidosis at birth. Cerebral redistribution may be used in association with other clinical elements in decision of delivery of LFGR fetuses, even in cases of normal umbilical artery. After 34 weeks, the risk of serious morbidity and mortality is low, and the delivery of fetuses with LFGR will minimize the long-term sequelae. The paradigm that a normal umbilical artery Doppler in third trimester confirms normal pregnancy and does not need any further Doppler evaluation of the fetal vessels definitely needs to be modified with important impact upon the clinical follow-up. How do you manage? There is no effective intrauterine treatment. The objective of a correct management are early diagnosis, prevention, and reduction of risk factor where possible, and surveillance of the fetus with growth restriction. Delivery at the best moment. If delivery occurs before 32 weeks of gestation, consider magnesium sulfate for neuroprotection of the fetus. If delivery before 30 weeks of gestation, 34 weeks of gestation, steroids should be given. And Doppler ultrasound is the chief tool to decide when to deliver. What is the aim of delivery? You want only a live fetus or intact survivability? This is very important. When to deliver? Gestational age decompensation is the primary determinant of perinatal survival. Neonatal care available dictates the gestational age of delivery. Less than 32 weeks, every day gained is useful. Every week gained outcome improves by almost 40%. Venous Doppler helps delay delivery. 32 to 34 weeks, steroids delivery once you see absent or reversal of umbilical artery. When you have early onset FGR, placental insufficiency mediated, fetus less than 10 percentile, poor growth velocity, especially flattening of growth in second and third trimester, asymmetrically small, onset before 32 weeks, abnormal umbilical artery, uterine artery Doppler, abnormal MCA like a normal or low PAP-A in first trimester screen, frequently associated with preeclampsia. This is a stage-based approach to management of fetal growth restriction early onset. Please take a snap of this, take out a printout, laminate it, and keep it in your labor ward. Early onset. These are 4 stages. If it is stage 1, that means severe smallness or mild placental insufficiency, estimated weight less than 3rd percentile, CPR less than 5th percentile, umbilical artery more than 95th percentile, uterine artery PI more than 95th percentile, monitor weekly, and gestation age and mode of delivery, 37th week you should deliver. You can do induction of labor and deliver vaginally. If it is stage 2, that means severe placental insufficiency, whereby you have umbilical artery showing you absent end-diastolic flow. Here it was increased resistance. Here it is absent end-diastolic flow, reversal of flow in aortic isthmus. Do twice a week monitoring, deliver at 34 week by C-section. Stage 3, low suspicion of fetal acidosis. Umbilical artery shows you reversal of end-diastolic flow. Ductus venosus pulsatility index more than 95th percentile. Do monitoring daily. Deliver by 30 weeks by C-section. Stage 4, high suspicion of fetal acidosis. Ductus venosus showing reversal of A, that is a third wave. CTG abnormal, fetal heart rate showing deceleration. Every 12 hours you should monitor and deliver anytime after 26 weeks by C-section. If it is less than 26 weeks, please counsel with the patient's relatives and decide whether she needs to be delivered vaginally or they want C-section. Now, late onset fetal growth restriction, mild placental insufficiency, fetus less than 10 percentile, flattening of the growth curves in third trimester beyond 32 weeks, normal umbilical artery Doppler, low PI in middle cerebral artery, and the CPR, cerebroplacental ratio, is less than 1. Uterine artery Doppler is abnormal, like a normal or low, not associated with preeclampsia. Monitor weekly Doppler growth and LICO. Now, if gestational age is more than 37 weeks, deliver, allow vaginal delivery. Gestational age less than 37 weeks, give steroids. Doppler of uterine artery more than 95th percentile, CPR less than 1, estimated age less than 3rd percentile. Any one of these three, it is abnormal and immediately deliver. Monitor for serial worsening of middle cerebral artery. Optimal gestation age to deliver the fetus with late onset FGR, more than 34 weeks, delivery at 37th week of gestation with increased PI even in umbilical artery. Don't wait till term beyond 37 weeks. Delivery at 37, 38 weeks cases with normal umbilical artery Doppler, but modified middle cerebral artery. Timing of delivery is based only on middle cerebral artery Doppler. Please remember this very clearly. Early admission is recommended in women with spontaneous labor with a small gestation with fetus in order to instigate continuous fetal heart rate monitoring as suggested by RCOG in 2014. Fetal heart rate monitoring will be interpreted more cautious than usual. I am not finished. This is LIUGR or LFGR. It should be, I should not use IU. The onset after 32 weeks, PIH need not be there, high index of suspicion. Umbilical artery Doppler may be normal. Always combine umbilical artery with MC and CPR for decision making. Now, most important thing, what does not work in fetal growth restriction? Number one, bed rest. You confine the patient to bed, don't allow her to get up, ask her to pass stool and urine in bed and all that. That just doesn't help. Maternal oxygen supplementation, maternal nutritional supplementation, low dose aspirin, beta blockers, calcium channel blockers, plasma volume expanders, nitric oxide donors, L-arginine, vitamin C, Viagra, all these things do not work. There is no point giving all these things to just satisfy your patient or satisfy yourself. There is something which is coming up, and this ever rest has come from these green words, green letters. Does vascular endothelial growth factor gene therapy safely improve outcome in severe early onset fetal growth restriction? We are waiting for the results. If so, we will be able to give this gene therapy to these fetuses, and we will be able to take away all the cases of FGR. What are the take-home messages? When to monitor begins with the onset of intact survivability in fetal growth restricted fetuses. What to monitor is the combination of arterial venous Doppler with input from biophysical variables in compromised fetal growth restriction. How often to monitor depends on the anticipated speed of clinical deterioration. Delivery is indicated when risk of fetal acidemia and or stillbirth outweighs the likelihood of meaningful extension of pregnancy. Each word is important. And lastly, differentiate between constitutionally small and fetal growth restriction by composite fetal growth curves, like a study and Doppler. Many so-called constitutionally small babies will be redefined as fetal growth restriction once you add CPR, uterine artery Doppler, and estimated fetal weight below 3rd percentile. Doppler of umbilical artery MCA ductal xenocytic isthmus are useful for monitoring and timing of delivery of FGR. Pathological growth restricted fetuses have higher morbidity and mortality rate and hence require more intense surveillance. Thank you very much, ladies and gentlemen, for your patient hearing. Sorry, we are so late now. It's almost 8:40.
Thank you, sir. Thank you so much for your brilliant presentation as usual, sir. Sir, you simplified this complicated chapter so well that I think everyone must have been benefited from your talk. And one thing I would like to add, sir, that we obstetrician, if we want to reduce neonatal mortality and morbidity, we must follow your instructions. We should identify the things well in advance, what are the causes of FGR, and we should follow stage-based approach to management of FGR. And you have rightly pointed out, sir, that unexplained stillbirth is one of the cause of undetected FGR in last trimester. So we should follow all these things in 3rd trimester, and cutoff value, as you told, that is 32 weeks for best diagnosis of FGR. We should know all these things and steps in appropriate evaluation of FGR. We should follow all the steps for evaluation of, and it should be serial evaluation. So everything you said told very well. And to say something or to say nothing, it will be very difficult for me. So it was a great honor for me to chair your session. And we have already heard your talk once in Patna, way back for Alembic company. And you had told this topic. So I have put all your chart in our labor room, how to manage this FGR in case.
See, as time passes, we come to know more about this. There are a lot of groups world over who are working so much on fetal growth restriction.
Yes.
We take everything ready-made from them and put it into practice. But today, early onset, late onset, this is one thing we have to keep in mind. The division line is 32 weeks and umbilical artery MCA Doppler is a combination. Never do only umbilical artery. It has to be middle cerebral artery also. And even if the baby is growing well, till 32 weeks, 34 weeks, please don't think that everything is normal. Always do a 3rd trimester ultrasonography along with Doppler, both umbilical as well as middle cerebral artery and cerebroplacental ratio.
Yes, sir.
If you want to
Doppler should be done in 3rd trimester, sir.
You want to avoid unexpected 3rd trimester deaths.
Yes.
Thank you.
Yes, sir. Thank you, sir. And before we finish the talk or finish this session, we close this session, I would like to thank Dr. Sneha and Dr. Monica for inviting me to chair this important session, and my best wishes to both of you for your future endeavors. Thank you, Dr. Sneha.
Sneha, thanks a lot. And wish you all the very best for your future endeavor. You'll be a very hardworking person.
Thank you, PK sir.
Yeah, thanks a lot.
Thank you, sir. In fact, it is
Many thanks for the brilliant talk, sir.
privilege to have you, sir. I'm sure it has, I mean, majority of the obstetricians will definitely, change their practices of going for a 3rd trimester scan. Definitely, majority of they just feel that, the baby is quite good size and now not to worry about what is an important message sir has given. It's all about the CPR, and we must go for Doppler during 3rd trimester to avoid the unexplained, so-called unexplained death. That's what, very important message from sir. Thank you so much, sir. It's always a pleasure to listen to you, and it's very, very helpful coming from you. So, Monica, are you here?
Yes, ma'am, I'm there.
Thank the chairperson, Dr. Pramila Modi, madam, and Amita Sinha as well. Thank you so much, and looking forward to visiting you personally in July. I know I have two invitations from your side, but I'll be coming for sure. Let me just get over by the coming events, and definitely I'll be there in Patna. Thank you so much.
Most welcome.
Thank you so much, Amita ma'am, and thank you very much, Pramila
Thank
ma'am,
you so much.
for being chairperson. Thank you, PK Shah sir. Thank you
Yeah.
for the brilliant talk. Thank you, Sneha ma'am, for giving me this opportunity to be the coordinator for today evening. Thank you very much.
Thank you. Thank
Wish
you.
you all a very good.
All the stalwarts, I will
Thank
not
you.
take the names again. I can see Chitra still here. If you are here, you can make few comments. Chitra? Okay. So, yeah, so we have, almost 250 players here today, and we had good interactive comments also in the chat box. Very happy. Does anybody want to make any comment? No. So thank you so much once again. Thank you, everyone. So thank you so much. Good night.